I have known before. Please, and hope that you'll be able to stick with us for this day. My name is Louis Hassel. I'll be your moderator for today. Our first speaker today is Dr. Eric Begbu, who is from the United States and the UAE of both, I guess. He'll give us a little introduction of himself, who's going to talk to us about endoscopic bariatric
Thank you. Thank you, Professor Faisal. Thank you so much. Morning, everybody, and thank you for the opportunity to be here. It's exciting. So we're going to be a little bit informal to start with, since we have a few minutes before 9. Sir, see you. And but today we want to, of course, talk about endobariatric therapies and introduce myself a little bit to begin with. And yeah, and of course, we're going to have some time for questions at the end. Okay, good. All right. So as a gastroenterologist, which is what I am trained to do, and I've been doing it now for the last 24 years of my life, I think. And we tend to sometimes zero in on a particular field. But over the last few years, the advent of endobariatrics has really come into play and has allowed us to expand what we do as gastroenterologists today. You know, weight loss is a cornerstone of concern globally, and gastroenterology now plays a pivotal role in managing weight loss patients, and that's what we are going to be focusing on today, which is very exciting. So our practice in the United States encompasses obviously general gastroenterology, weight loss, and other aspects of what we do. And you know, this is also a global need, and so we continue to expand our frontier past the United States into the Caribbean, into Africa, and of course into the UAE as well. So this is very exciting for us. Today we want to be able to walk away with 3 things. I always say that whenever we get together in a room like this, no matter who is on the podium, we must be inspired, right? That's number 1. And then number 2, we must have an awakening of our imagination. That's number 2. And number 3, we must implement, right? So if you hear everything I say and it's just nice and you don't implement it, then it doesn't mean much. So inspire, imagine, implement. That's what we want to do today. And at the end of our day today, I trust that we will have achieved those, at least the first part, the first 2 of those 2 things: inspire you and inspire the imagination that is needed. So obesity, the world over is being run over by obesity. So imagine that 30% of the world today is obese. That's an incredible number. 30% of the world is obese, not the United States of America, the world. 30% of the world is obese. And this trajectory, it won't be long before we, unfortunately, may have to say that 50% of the world is obese. Just think about that. And obviously, the United States leads the charge in obesity, but there, number 10 is Indonesia. Who would think Indonesia will be on this list, right? But that's just to show you the global impact that obesity has, and the growing concern that obesity has, which is why we know that there is obviously a wide and an encompassing need that needs to be met. So if you're a gastroenterologist, this is a bright day for you, as it is for me, or if you are in the weight loss space, this is a bright day for us, because there are lots of people that need what we have today. The economic impact of obesity is ever increasing. As you can see, it just impacts the whole world. No matter your economy, there's an impact there. Then, of course, the personal impact of obesity, I don't need to tell you. The metabolic syndromes, as we know, diabetes, high blood pressure, CVAs, cholesterol, infertility, then the social impact, right? People don't feel their best. They don't have the how do you put it, the productivity that they need. There's depression that's associated with obesity, so much impact. So when it comes to weight loss procedures over the years, so to the right of the graph over there, surgeries, right? So the bypass surgeries and duodenal switch surgeries, and then to the left are, the pharmaceuticals and some of the simpler things. So endobariatrics lives in the center. So that's where we are. We are right in the middle there. And so we're going to be, I'm talking about this. So the endobariatric options that I plan to speak on today are number one, ESG, or endoscopic sleeve gastroplasty. ESG has become probably the number one non-surgical option for weight loss from an endobariatric perspective, of course. Then bariatric revision, as we like to call it, specifically targeting the patients who've had bypass or sleeve in the past and who've regained weight, which is a big issue. And then the gastric balloons are ever evolving, and we're going to talk a little bit about gastric balloons today, but I truly want to focus more on ESG and revision if I can. So ESG, as we like to call it for short, reduces the stomach size endoscopically. We are able to use a device that's made by Apollo Endosurgery called Overstitch, and we're able to pretty much make the stomach smaller. I'm going to show you a video in a minute. Again, there's an unmet need when it comes to the treatment of obesity, because for years and years and years, even when I was in medical school and all the way to residency training, the fellowship training, the thoughts of obesity were either, join the gym and eat right or have surgery. And for many years, there was this big gap between those two extremes. And now the gap is being bridged by endoscopic options for weight loss. So Apollo ESG, as I mentioned, is what we're going to talk about today. And hopefully this little video here will be able to play. Let's see here. Oh boy, okay. So, apologies. Okay, well, unfortunately, the video that I wanted to show was not loaded for some reason. I'm not sure why, but we're going to go over it. But pretty much, we're going to show an animation of how ESG procedures are performed. All right, so what does ESG do? As I mentioned already, we endoscopically suture the stomach, of course, working in the area of the greater curvature of the stomach, so you can see the post feature, if you will, of the stomach after ESG. We are creating a sleeve effect without the surgery. We're reducing the gastric capacity by as much as 70 to 80%. And the advantages obviously are many. It's outpatient procedure, it's non-surgical, minimally invasive, less risk, as we're going to go into the published data on that. And then, of course, less time away from work and less time away from allow people to get back to work very, very quickly. So our patient pathway obviously starts with the right patient. You have to select the right patient, right? Not everybody is the right candidate for ESG. There clearly are some people who should not have ESG, namely people that may have other psychological reasons why they shouldn't have that kind of a procedure, or people who have anatomy that makes it impossible to have ESG. But most people are good candidates for this. So of course, there's the patient selection, there's a procedure, and then there's post-op care. We emphasize post-op care at AMG Weight Loss, where I work, where I lead, very much so because we saw over the years through the experience of gastric bypass and gastric sleeve patients that majority of the failure happens years after the surgery because many of these patients lacked adequate follow-up care. So we are very, very big on that. We have a whole team of dietitians and behavioral therapists that work with our patients. But let's get into the data because this is super important, right? So this is where the rubber meets the road. So the MERIT study stands for the multi-center endoscopic sleeve gastroplasty randomized interventional trial that was published in 2022. And it has become the pivotal study for ESG. It's become the study that's put ESG on the map, and the study that's allowed the FDA to currently approve ESG as a non-surgical weight loss procedure in America. So the study was very rigorously designed, involved 9 centers, 208 patients, and patients were randomized, of course, and it was a double-blinded study. So patient selection, obviously for people who were class 1 to class 2 obese, meaning BMI of 30 to 40. And the primary endpoints was, number one, we wanted to demonstrate that patients were going to lose at least 25% of their excess body weight, right? That's number one. Number two, we wanted to make sure that safety, meaning complications, were less than 5%. And so those were the 2 main primary endpoints. Secondary endpoints, of course, were driven towards the metabolic syndromes, high blood pressure, diabetes. And this was a 2-year study as well. So it's a long study, well done, well designed, multiple centers, lots of patients in it. And so was truly powered to demonstrate if this was going to work or not. So pretty much what we found with the Emirates trial is as follows: that the target we said that was set out for the Emirates study was 25%. If people who lost 25% of the excess body weight, then we say this is a good technique. Well, so in the Emirates study, beautifully, 49% of patients lost that amount of weight. So scratch out. Patients lost 49% of the excess body weight. So twice what was planned or projected or hoped for. Again, the target was 25. We are right at 50%. And then another durability of the study was it was a crossover study. So at the end of 1 year, those that were randomized to lifestyle modification alone, which were the control group, where they had the ability to cross over to the ESG arm of the study. So these people had the ability to now undergo ESG procedure. And what we found with the ESG patients, or with the control patients, is that they achieved the same 49% loss in excess body weight. So when you compare that to what's the weight loss that they had in the control group, was only 4%. So only 4% excess body weight was lost in the control patients, which is a 45% delta. So clearly showing that ESG is a long-term solution for weight loss with proven, with very strong results that we can see. Now, when it comes to the comorbidities or the metabolic syndromes, we saw amazing impact: 92% for diabetes, 83% for NAFLD, 67% for high blood pressure, improvements with ESG compared to the controls. So the controls, pretty much nothing much happened with those metabolic syndromes there. So the Emirates study was also looked at the effect of reflux, whether reflux got better with lifestyle modification alone versus ESG. And again, the demonstration and the just blew it right out of the water. People who had reflux got better after ESG, and people who never even had reflux definitely did not develop acid reflux. Now, this is one of the things that makes ESG a bit different from laparoscopic sleeve gastroplasty, which has been the standard, right? Which has been there for many, many years. For the laparoscopic patients that undergo surgical sleeve, many of them develop reflux afterwards. And so with ESG, that doesn't happen. And we understand that is because of the way the anatomy is modified with ESG, where the stomach is foreshortened versus lengthened in the laparoscopic version. All right. So safety, right? Is it safe? Is this going to work? And number one, we know it works now. Is it safe for patients? So in the Emirates study, the complication rate was rated at about 2%. Again, remember the target was 5%. So if we are able to demonstrate that safety was less than 5%, then we say this is a good thing. So with the Emirates study, 2% in severe adverse events was the number, which is truly a remarkable number. So if you put that again in perspective with surgery, these numbers are a whole lot less than surgery. The series in surgery, we show complication rate as high as 30% in some series. So this is a big deal. So now we have a minimally invasive outpatient efficacious modality with less risk. What's not to love, right? That's what ESG is able to do. So most of the adverse events that we see with ESG is in the first week, and of course, it's with abdominal pain, nausea, vomiting, the typical things. As time goes on, the side effects and symptoms will tail off as well. So first week is typically what we see, and even in our practice, where we've now performed well over 1,000 of these cases, our complication rate is at about 0.1%. We've had one person out of over 1,000 people that required intervention, and we'll talk about that some as we go along. So this is even better than the Emirates study showed, right? All right, so these pretty much showing that ESG is superior to lifestyle modification alone. So yes, it's great to adopt a healthy lifestyle. There's no doubt about it, but sometimes some people need help. And if they can get that help non-surgically with minimal invasion, even better, right? All right. All right, so adverse events, what some of them you would expect, some of them are probably going to be new to you. And I would emphasize the perigastric fluid collection, which is what one of our patients had, one of over 1,000 people. Easily treated either radiologically by draining or by EUS, and which is what happened with our patient, had EUS, got it drained, and able to return. So very, very, very simple as far as that goes. But there's definitely, for gastroenterologists, there is a learning curve to ESG. I've been involved in therapeutic gastroenterology all my career. And I say, and I don't even overemphasize when I say this, ESG has been the most challenging new technique to adopt for me on a personal level. Doesn't mean it's not, there is a learning curve. There's no doubt about that. So if you're going to have an ESG done, you probably don't want to go to the guy that's done 2. You want to go to the guy that's done 1,000, right? Because there's a learning curve. There's no doubt about that. But the good news is that the side effects are absolutely very, very minimal at best. So just presented to you the Emirates study, which looked at class 2 obese patients. Well, so here's another study that was a multi-center study as well, within the US and Brazil. And this looked at a whole lot more patients than the Emirates study did. 400 patients or so we looked at here. And these are class 3 patients. So these are people who are much more with BMI of 40 to 65, so much bigger than our married patients. And again, the results are pretty much identical, almost anyways. We saw remarkable weight loss, as much as 20.3% of total body weight loss over a 36-month period. So it's a 3-year study. And we also saw improvement in diabetes and other metabolic syndromes. And the complication rate in the study actually mirrors what we see in clinical practice, about 0.5% rate of serious adverse events. That's very close to what we see in real clinical practice. Like I mentioned, in our practice, about 0.1%, but I know practice is about 0.2, 0.3, so pretty much around that number. Key thing is it is safe and it works. So that's amazing. All right, so we've kind of gone through this already. Who should have an ESG? In my practice, I'm an adult gastroenterologist, so I stick with adults. I don't do children, so we don't do anybody younger than 21 in our practice. And as far as age, the upper limit of the age goes, there's no true upper limit really, but there's some reason, of course, there's a limit to the reason that can be applied. So in our practice, I think our oldest patient with ESG was 67 or so. So that's pretty much somewhere in that range. And of course, the BMI selection, as we already mentioned, we know that we have clinical data that will suggest that we can use this for class 3 obese patients as well. All righty. So who should never have an ESG? Okay, so that's important. Who should never have this stuff? Somebody who has a gastric cancer, obviously. Somebody has a large hiatal hernia. That's somebody that we want to avoid. So everybody undergoes a pre-ESG endoscopy in our practice to ensure that we exclude all these things. People that have affective disorders, anorexia, for example. Obviously, pregnant women, nobody touches them. People who are coagulopathic for whatever reason. All righty. Other considerations that not as important, but again, these are very common sense to those of us that practice interventional medicine. I won't bore you with that. All righty. So we've talked about this a bit already. I'm going to briefly talk about the balloon procedures before I jump into revision, which is another exciting aspect of what we do endoscopically. So balloon procedures became the introduction for me personally into the weight loss space as an endoscopist. So in 2016, the FDA approved the Obera balloon in America. And so since then, we've been involved in endobariatrics. The balloon procedures are fun. They are fun because they are quick, they're easy. They are patients love balloon procedures because in their mind, there's no alteration to the anatomy, which is big. And so because not everybody's ready and not everybody needs surgery or needs ESG for that matter. So we still perform quite a bit of balloon procedures in our practice. And the Obera is the #1 balloon in the world. In America right now, there's only 2 balloons that are available, which is the SPAS 3 balloon and the Obera balloon. There are many more available all around the world. You all probably have more experience with those than I do because they're not FDA approved in America, so we don't have them yet in America, but we're hoping that they will come to America as well. But so we know the balloon works very well. It's 4 times preferred over surgery by patients. And that has been our experience as well. So again, placed through endoscopy, balloon is not tethered to the stomach, it's smooth, doesn't cause much ulceration and things like that. We don't tend to see that with the Obera balloon or with the SPATs either. Let's see if this works. Okay, so my videos don't play, so whatever. All right. So Obera now is being placed in over 80 countries. Really, really beautiful. And of course, the most important thing for us in what we do is to hear the stories and see the real life people whose lives have been transformed by non-surgical weight loss, and the joy and the passion and the confidence that they exude when they see themselves or when they come to the office and their follow-ups, and they send me pictures. I get pictures almost every other day from patients all around the country, and it's just incredible. So that's one of the greatest rewards of practicing endobariatrics for sure. All right, so I'm going to skip through some of this because balloon is not truly what I wanted to focus on today, but I'm going to go on to Apollo Revise. So revision is such an incredible concept because, again, a lot of patients have to date undergone either gastric bypass or gastric sleeve surgery, and then we know that come around that 50th year, 60th year onwards, weight regaining begins to happen. And there are multiple reasons for that, multiple reasons. And for decades, pretty much for the entire history of weight loss procedures, what do you do for the post-gastric bypass patient, right? Has always been the question. And many times there's never been a good answer. Even when they go back to their bariatric surgeons, the bariatric surgeon will say, well, you've had gastric bypass. Now, for the people who've had gastric sleeve, they can convert them to gastric bypass. Or, however, for the gastric bypass patient or the Roux-en-Y patient, they are like, well, there's not much we can do. And what we saw endoscopically was that these folks, their remnant stomach or the gastric pouch had gotten much bigger than their immediate post-op size, and the gastric outlet has also widened many times up, 10, 20 times more. And so these folks will experience early satiety, but it didn't last as long as it used to after the original surgery. And that's one of the reasons that they begin to regain weight, not the only reason. So transoral outlet reduction, or TOR, is what we call bariatric revision. And again, there's a video that's not going to play, so I won't bore you with that slide. So yeah, so weight regain, like I mentioned already, occurs again because of dilation of the gastric pouch and the outlet. So they get bigger and they can hold more, they can eat more frequently, and they can, and then over time they begin to regain weight. So the process is the same. You have to get the right patient. You have to, obviously prep the patient from a procedure standpoint, creating and emphasizing expectations and follow-up care. What I see universally in my practice is patients tell me that they've lacked that adequate follow-up care after their first surgery, and many times that becomes the reason why they failed. So we have level 1 evidence that suggests that TOR reduces weight regain after Roux-en-Y bypass. So this was a study that was conducted and published, I believe in 2021, I believe it was, and it was called the Restore Trial. The design was in 2013, and again, you looked at people who've had gastric bypass or Roux-en-Y surgery and underwent the TOR procedure. This was actually pre-revision days. So these patients underwent a suction type based partial thickness suturing, and the results were great, but the effect didn't last as long. So we knew that we could do better, and of course we did. But again, reducing the stomach or the pouch size and outlet size is proven to lead to more weight loss for sure. So when it comes to safety profile as well, the safety profile is pretty much the same as we saw with ESG patients. So complication rates are extremely low. Now, in 2021, this was that I was referring to earlier, we looked at this, it was a peer-reviewed 5-year study, endoscopic versus surgical revisions. And so this was a comparison, if you will, and pretty much the results of endoscopic revision and surgical revision were almost identical, and the longevity was also pretty much identical. So showing that endoscopic revision was just as efficacious as surgery, but much safer. Less and fewer serious adverse events were recorded in the non-surgical arm, which is where we live, versus surgery. So yeah, so who should not have these procedures? Same as we just went through, so I'm not going to bore you with that. The key thing again is that these procedures are meant to restore the stomach pouch, if you will, and the outlet, and reduce the outlet so that patients are able to have that sense of satiety again. It also has shown to lead to improvement in medical issues of diabetes, dumping syndrome, which is big. As a matter of fact, when I first started doing endoscopic revisions, one of the driving reasons people came to me was they had this dumping syndrome from their first surgeries, and the revision has been shown to make that even better. But very, 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 very important in this patient population is establishing expectations is really important because sometimes these people they feel like they've failed already. Because when somebody undergoes surgery, such as Roux-en-Y surgery or even gastric sleeve surgery, and they see this amazing weight loss, they lost 100 pounds, and now they see themselves put on 70 pounds of the 100 they lost. The sense of failure in that you just can't imagine. And when they encounter people like me, and we're able to inspire, and we'll be able to deliver hope again, many times they feel like it's too good to be true. But one of the things I think that makes endobariatrics so attractive is the fact that they understand they don't have to go through surgery again. and also more importantly, that we have a very robust system of support after, because the aftercare is super important for these folks, because they're very quick to give up on themselves and upon their dreams, but
1 minute, Eric.
thank you. But that's why we're here. So listen, I can talk all day about this, so I won't. But thank you so much for your attention, and I trust that in this little time we've been able to inspire you, right? We've been able to let you know that this is possible. So imagination has been kindled, and we can implement. The goal is to make this available to every patient all across the world, because the need is global. So thank you.
Thank you very much, Eric. Do we have any questions for Eric? One quick question I might have is, patients who get balloons, do they get abrasions? Do they get erosions? Do they get chemical gastropathy? What is the biopsy follow-up on those patients?
Yeah, that's a great question. So we don't tend to see that a whole lot. Now, especially with the Obera balloon, the way it was designed. Now, the early generation balloons are like Reshape, that is no longer available in the market. Reshape was associated with the ulcer rate in Reshape was very, very high. That's why it's gone. But with Obera balloon and SPAS, not as much. So yes, we do see some gastritis for sure. We do see some esophagitis. So all these folks have to be on PPI, pre-op, intra-op, and post-op, and they have to be on PPIs for 6 months after their procedure. As long as the balloon is inside too, they're on the PPI twice a day. Yes, sir.
Let me present you your certificate. No, one more question. Yeah.
I'd like to ask if the insurance coverage has any difference or impact on your choice of procedure. For example, different insurance and also different BMI maybe coverage, and the chronic disease, for example, if the patient has diabetes or NAFLD, maybe the insurance cover better. Is there any impact on your choice?
Yeah, so that's a tremendous question. So yeah, indeed. Insurance, you gotta love them, right? Gotta love them. Gotta love them. Anyway, yes. So the short answer is yes to all of them. So the patients, let's talk about patient selection and how I make a decision. And first of all, I never try to decide anything for anybody. But if I see a 5'5" lady who is 330 pounds, and she tells me she wants to have the balloon procedure, I have a very serious conversation. I said, listen, the balloon, yes, may help you, but keep in mind, we're going to remove it 6 months if it's Obera, 8 months if it's SPAS. Then what will happen then? For those people, I tend to veer them towards EFG because we're looking for more long-term control. Now, in America, the FDA has approved EFG and revision by Apollo. Insurance coverage is still extremely spotty. There are a few reports that there may be some coverage here or there. It's not mainstream yet. We hope it will become. The FDA has also approved the Obera balloon as a therapy for NAFLD. So, now has that translated to them paying for it? Unfortunately, has not. So yeah, it continues to be a major consideration for us every day when patients come in if the insurance will cover. But yes, thank you for that question.
All right.
Thanks.
Well, thank you very much.
Thank you.
Thank you. Thanks. Wow, very good presentation. So our next speaker this morning will be Dr. Ariadna Masso from Spain. And she's going to be talking to us about GI technologies and insights, monitoring patients, empowering clinicians. So welcome.
See my slides. I think this is the link, please. Yeah. Yeah, we had a 14. Yeah, so yes. Thanks. Sorry about that, setting up the how the commands are different. So yeah. Right. Almost set. Right. Okay. Okay, perfect. Here we are. Well, good morning, everyone. My name is Ariadna Masso. I'm delighted to be here today, very excited. I'm coming from Spain, actually. I have lived in different countries, so you will see that part of the presentation also has some biases referring to the UK market, where I lived for 10 years. But the goal really is to talk about technology and how more and more we can empower clinicians and also patients in a world where technology is really shaping not only our daily lives, but also like healthcare, right? And to do that, and obviously, 2023 has been a key year in terms of technology, especially with AI, right? We hear a lot talking about artificial intelligence, but there is like a lot to unpack. It's such a big topic. So I hope that my talk will give a bit more granularity as to how we can support patients and follow-up care, for example, that was just mentioned now, through technology, but also empower the clinicians to better make decisions as well before, after, and outside the clinic. So for follow-up cares, for example, as well. So to do that, though, I wanted just to share my story before we dig into the details of the presentation. And I appreciate I'm probably an outlier here because I didn't study medicine. I'm here more as a patient, actually. So my background is essentially started studying business administration, business management, graduated 2011, went to Paris to do my business management international master's degree there, started my career in finance, so a completely different space. And I was on Forbes 30 under 30 in 2017, and that really gave me a lot of insights also into tech. And that's how I started to be very interested in the technology space. But really what made me transition to where am I today is my diagnosis of colitis. So in 2019, I was living in the UK still, and I started, well, I felt very unwell, and all that IBD diagnosis started. In my family, we have a history with IBD, so it was really a kind of dark moment, I would say, very tough period. And that really led me to study nutrition science because nobody really told me how I could manage my flares outside medication. And we're going to talk about it, right? Capturing this 360 and holistic approach. And that's how Sano came to be. So I'm the CEO and the founder of a company called Sano Health. And I'm going to tell you a bit more about later, but it's, in essence, we are a digital platform connecting patients, clinicians, and researchers, and really helping with data insights to support the patients, but also the clinicians. Right, so let's go. So what were my main learnings in this diagnosis process? So one of them was, I mean, waiting times are really long, right? And I think we kind of, all of us know about that. But basically for me was in some of the trusts, specifically in the UK context, up to 1 year waiting time to see a consultant, average 6 months, trying to fast track, private 2 to 3 months. So not ideal, isn't it? Especially when you're flaring and you don't really understand how to manage your symptoms. The other big learning was this lack of knowledge. So as a patient, really not understanding, okay, what is it I can do, where I can go outside the clinical setting to find reliable science-based information. That was a real struggle for me. And I mean, when we see these statistics, 80% of patients still go to Dr. Google to try to find the way to manage their symptoms, right? And there's a lot of confusion for sure, because not everything is evidence-based. So that was another big learning and challenge. The other one was, okay, my consultation with the consultant arrived after on average 6 months, even 1 year of waiting time. And then it was literally 15 minutes max. And this consultation is then kind of, it was very challenging because like, okay, I had so much to tell over what happened over my flares for the last month and months. So we see this very often as well through our platform. Our patients come very frustrated saying, how can I capture as much data? So in 15 minutes, I can convey the message and the clinician, the doctor can see, even the nurses, right? They can understand in a quick glance what I have been through. Another challenge. This is the one that really was kind of a tough one. So in my view and in experience, and we see that also in a lot of data when we see patients with our platform, is this trial and error approach. Because we're going to talk about it, but typically not general protocols might work for different people, right? And some medications, for example, can cause, I mean, in my case, right, I had a lot of flares and I had to adjust and really understand what medication could work. So this trial and error component is also challenging to manage, right? So how we can make sure that we empower the patient, but also we can let the clinician know about what has worked, what's not worked in a more efficient way. And probably the last one is this lack of holistic data. So this means that, typically we focus a lot on medications, but what about nutrition? What about, for example, stress levels? I mean, we see very interesting data sets correlating flares with stress and anxiety, right? And actually, when we see the patients with more anxiety, obviously the flare just grows and it worsens. So it's very interesting, and definitely where we're seeing healthcare going is towards a more holistic, with 360 kind of approach towards data. So in essence, right, this is kind of me trying to figure out, okay, I had the medications, but also this stress, anxiety around the flares, but also the nutrition component, as I mentioned before, for me was key, was very important. And nobody sat me down to explain, okay, this is how you can manage your IBD with dietary changes and based on where you are in remission or acute flares, like how you can manage that, not only, or let's say beyond the pill, right? So this holistic approach, I think, is a big one, and also a key message is that one size fits all approach doesn't work anymore. And also another big trend we are seeing, and also through technology, is this path towards personalization. To be able to personalize, because what works for you might not work for me. So obviously we have protocols, but how we can narrow it down to the individual level, also for more efficiency. Right, so here we go about the solution, right? So what can we do? We have all these challenges, right? How we can, again, patient and clinician, how we can find common points and ways to make this work. So obviously tech and data are here to help us empower and support these challenges. So with all I told you about, what I put is a few years ago, so I put an MVP, a minimum viable product, was an app to help me basically track my own flares. And this is kind of a screenshot actually of, you can see how the app looks like today, but had a much more simplified version at the time. And it was about tracking medication, it was about tracking symptoms, but also nutrition, sleep, anxiety, stress. And with all that, see data patterns. And I shared that with other patients. And surprisingly enough, all of them were using it. And when they were going to the clinic to see the doctor and nurses, that would show basically, okay, this is like my progress. And we started to narrow down then with data patterns, right? To dig more into granular detail as to how we can issue reports, for example, or visualizations that can help the clinicians much faster in a very limited of time. They can have a picture of what's happening to this patient. And in essence, this is what we have built and what we are offering today, which is this kind of integrated platform that, you know, starts from patient-reported outcomes and then basically translates into the clinical setting as to what's happening, what might be good to look into. I mean, not obviously replacing at all the clinician's decision, but supporting and trying to provide an assistance. And most importantly, making sure that there's some sort of automation with questionnaires and follow-ups that can then go to the patient. So the patient goes outside the clinic feeling heard and feeling, okay, there's a plan here, there's follow-up, these are the guidelines, and how technology can make this more scalable and sustainable. So I wanted now to walk you through how the patient journey looks like in a digitized context. And I don't know how many of you use technology in clinic or for your patients. I mean, I would love to hear that now or later in the Q&A. But what we are seeing is this very adaptive, right, pathway where first starts with the clinic, patient onboarding. It can be a QR code, could be a link, and basically all that already embeds the clinic's ecosystem and the clinic's clinicians with their own encrypted environment, integrating with their electronic health records, systems, etc. And before the consultation, the patient already receives questionnaires and already receives some sort of bit of a homework and prep. And this is something that, you know, we are used to this kind of pen and paper on the side, kind of still doing for the patients. And we realize that digitizing that and bringing that much earlier in the process is a win-win. There's more information to prepare the clinicians and the clinic for that appointment in terms of also prioritization, triage, but also the patient. The patient feels like, okay, I'm more empowered and this is what I can expect for the consultation. So here we're talking about questionnaires, we're talking about e-diaries, also more and more. What we are seeing is some biomarkers. So we can basically, well, we connect with labs, can be on-premise at the site, or at home. And basically based on certain symptoms from these questionnaires, the protocol might basically lead to that patient to receive a test. Could be blood, could be stool sampling as well. And one point that I find particularly important is the education. So content that helps educate and prepare this patient before the consultation. So again, our goal is to make things more efficient, right? There's very limited time. There's someone suffering and struggling, which is the patient, how we can make sure. So education, understanding, okay, what is IBD, what is Crohn's, what is colitis, what exactly I need to do to prepare, what I need to prepare for colonoscopy, how I can do that. We see, we get a lot of requests and a lot of people are very anxious about how I can prepare for a test, a colonoscopy, or my consultation. So all this education component we find specifically important. And then moving to the next piece of the patient journey, of course, is the consultation. So the day arrives where patient goes to the clinic, and the assessment already has data insights captured previously. So it's much more efficient. And obviously then there's the review of the protocol, tests, further tests might be done after that. Other specialists might get involved as well. And the last piece is obviously this follow-up, right, outside clinic, where basically the patient goes home and feels like, okay, I'm empowered, I know what to do. Here I have, you know, all the steps that I need to do outside the consultation until mostly maybe what, in 6 months or in 1 year for a next checkup, etc. So one of the key benefits where we see technology helping patients is really this data-driven insight to anticipate flares, right? And it's so interesting because I think we are getting to a point where, based on these patterns, and I will mention stress again, right? We see, for example, in the data sets, patients registering where have flares. What happens when a flare starts to build up? And we start to see above 60% of them report some sort of serious anxiety and stress. And then the flare builds up. But we also ask them questions. What do you eat? Obviously, what medication you take? What do you do? How you feel, right? And all this 360 approach is giving us a sense to then, go to this patient and send a notification when we feel the heart rate from a wearable is too high, and all this data starts to be the same. Say, hey, last time we had a really bad flare, these components, this same symptom group, this same stress level happened. Please slow down, get help now, or do this. Yeah. So it's more prevention rather than, a reactive approach, which in turn might help the patient, but also might help, avoid avoid, for example, consultation, avoid urgency down the line. So yes, these correlations are definitely very interesting, and we have a massive opportunity with us, with all this, data tech-enabled approach, where also dietary patterns play a role. So I said this holistic approach. Also the adherence. So something very interesting is what we were approached by different research groups and hospitals, and some of the protocols, and this is especially also not only clinic, but for research. We found some of the protocols only 30-40% of the patients finished. And obviously there were different factors involved as to why that happened. But adherence to treatment is a very common challenge we find. I mean, for research purposes, it's very hard to recruit patients, right? Based on inclusion, exclusion criteria, etc. And once we find these patients, it's a shame that, they drop out so easily and for many factors. But we found that through tech, we can help actually for retention. And again, it's all about empowering this patient with the information, the protocol study, and they feel like they know what to do exactly when. And alert when someone is thinking about dropping out, pausing, withdrawing, understanding why. So in 2023, we have participated in several research programs in the UK, in the US, Europe, and the average adherence rate was 89% of patients who finished protocol. And that, I find personally, this is very exciting and promising, right? Because through personalization, through this tech-enabled angle, we can retain patients. And that translates to better data sets, right? In the end of the day, for better research and better outcomes. So again, all these effects compounds. But obviously, I mean, we have now focused a lot on patients, but how does this translate benefits for clinicians, right? So for clinicians, definitely they have better data sets. They have better understanding on a 360 of how is this patient doing outside the consultation, and therefore they can make better decisions and faster, more efficiency. We spoke about these long waiting times earlier. So make sure that when the consultation arrives in 10-15 minutes, the clinician is empowered enough with visualizations to see not only what happened in the last 48 hours, but have more precise information of the last 6 months or even a year. So this 360 data insights over time is definitely game-changing. And we see that technology, with the support of technology, this is definitely here to stay. But another interesting key insight that we found, hearing all the feedback from the clinicians, is the efficiencies, right? Saving time in clinic. Because if they have less to do in terms of manual reporting, and they have already assessments captured from apps connecting with the patients, right? And all that plugs into the electronic health records in their system, right? So there is less admin, less bureaucracy to do. They can save time. So we start to see this win-win approach materializing. And we quantified, so we asked through our platform to clinicians, and we're talking about more than 2,000 who answered this question. And basically they categorize that they save around 50% of time in manual work just because of this tech-enabled approach in clinic. So again, it's very promising in the end to see how we can help and support the clinician side as well. And another one I find very interesting is, so we have talked about the patient, we've talked about the clinician, but research is obviously, part of this very important triangle. And in research, as I told you, right, we participated in several programs, and we started to see that through data and through tech, we can assess, we can spot different correlations and comorbidities, and then we can fuel up research for better outcomes. But this comorbidity side was very interesting. For example, just to tell you something now on top of mind, but for a cohort of female patients with gastrointestinal pelvic pain reported outcome through the platform, then we started to see basically associations with potentially endometriosis. And endometriosis, for example, is a condition we know very little about. There's not much research being done. On average, it takes 8 years to diagnose, and women have to go through 7-8 different consultant appointments to understand over this time. So we started to spot different correlations. And basically now we are enrolled in 3 research programs on endometriosis in different geographies in the world. But just to tell you that this comorbidity and this essentially how we can understand a bit better how this diagnosis of endometriosis comes from already capturing this earlier. It could be even a GI symptom, and could be pelvic related pain, etc. So find this particularly exciting. So yeah, we have obviously spoken a lot about the benefits of technology to support clinicians and patients. And obviously, I think we are living in such exciting times for this, because this tech and AI specifically are game changing, and they are just starting, right? I think we are just starting to embark in a very exciting journey. But obviously this comes with risks and challenges. It's not that easy to apply. And one of these particularly key risks and challenges, data safety, protection, which obviously we go through several consents from the patient, from the clinician. That's so important. Also considering every local different legislations, very different. For example, US with HIPAA, and different the regulations that MDR, the medical device regulation in Europe, for example, or governing the UK. And IRB approvals, right? So we had to go through different ethics committee approvals. So preparing all the documentation to ensuring how a platform like this is safe and reliable. I think that is absolutely critical and important. And especially when navigating and going towards AI-driven models. But essentially, this is my next point, right, about artificial intelligence, right? We have massive potential in front of us, but at the same time, we need to make sure that we train these models the right way. And that involves different pillars. One is ethics. One is also diversity. So are we making sure different population groups are represented? And I'm not even talking about gender. I'm talking about different ethnics, different, social, demographic, economic representations as well, and reliability, right? How we can make sure that these models have this system of feedback loops and they are trained, audited as well. So this is like kind of a new space. I mean, just 10 years ago or so, right? The EU, for example, confirmed this new regulation around artificial intelligence to be deployed until early 2026. So we kind of have a lot to do in a short period of time. And it's definitely a challenge to make sure safety, which is so important. But the big conclusion is that digital endpoints and technology are here to stay. And we should really try to leverage on those, keeping it safe, ethical, reliable, but definitely can make a huge impact for the patients. And then that can translate also to the clinicians for better outcomes. So yeah, just wrapping up really, but one of the conclusions as well is any type of software in the end should be reliable but easy, right? And UX, so the user experience, is something that sometimes is completely abandoned or overlooked, but in the end of the day is essential I mean, we, for example, anecdotally, but we ran sessions that are just called design-led product process, where we design different screens and we show the clinicians, we show the patients, and we ask them, do you understand how to navigate this? And it's very interesting because all of us, we are biased in a way. So just, starting from scratch and understanding how we can make a UX so simple and yet intuitive and yet able to capture all these data points is absolutely essential. And another key area is definitely the integration with electronic health records. And that's definitely a very interesting but also challenging topic, because every geography, every market has a different way to handle this, right? The US is completely different, but it has one big system, although different states have different, challenges there. But in Europe, for example, is to me, in my experience, one of the most challenges, because every single country in Europe has a different system. And for example, only in Spain, Spain is organized in different provinces and groups. Every province has a different system which completely inconsistent and very hard to reconcile endpoints to the others. So when we are asked to roll out in Spain and to work with every single hospital, there is definitely big challenge. So we need to find ways to overcome this for, again, the benefit, right, of how we can better support the ecosystem. But obviously, patients at the center, and for real, there's a lot of talk about patient centricity and not really much being done. There's a very interesting data point in a survey, and I can send you, if you're interested, the source, that was asked when 70% of pharma companies think that their patients are put in the center, but only 6% of the patients feel that actually they are considered and put in the center and heard. And this is, I think, staggering statistic to share the importance, right, of really putting the patient at the center, but also we cannot forget about the clinicians, right, with better tech to capture these data sets to make better decisions and save time, and in the end of the day, be more efficient and reduce backlog, which is considerable and remarkable. But yeah, I think the very last point really is feeling heard as a patient. And when I started this company, for me, and still, I mean, the clear mission is, as patients, working with clinicians and researchers to make sure that we can create a tech-enabled platform to support them to feel empowered, because it's such a tough journey. And basically, at least having some sort of companion that it's digital, because the personal one can always be there, because there's a lot of backlog and queues, and it's not that easy. So at least what can we do to make sure that this digital companion is there for us? And it's kind of funny when I say this, but in my team, we all have some sort of chronic gut disease. And I think when we found all of us and we found each other, it was like we instantly could connect and we could understand how important it is as patients to do this. So yeah, I would say as next step, I would love if each of you today, that when you go home later, you think about, okay, how in my practice or how in my daily role, daily life, I could use some sort of technology to support clinicians and support the patients as well. And obviously, I'm very happy to brainstorm, to assist, to help and exchange any further insights with you all. I left here my email in case that you want to reach out anytime. But I really hope that this was insightful. I know it's a different approach with a lot of tech and a lot of abstract things. But thanks so much for listening in. Appreciate that.
Thank you, Ms. Masso. Do we have any questions? I have one question. So beyond just digestive health, this is a problem in many other chronic diseases and so forth. Do you look to expand into other disease domains?
Yeah, that's an excellent question. So we organically actually expanded to other domains. So first, obviously, is digestive health, especially IBD. We also see a lot of functional, by the way, like IBS, irritable bowel syndrome type. But the second pillar is diabetes. So we organically expanded to that, obesity. And women's health is the fourth angle. And for example, the endometriosis example is an excellent case as to how organically with the data sets we started to appreciate, okay, there's something there and what we can contribute to that space, which is completely under-researched.
That's wonderful. Thank you so much.
Thank you. Absolutely.
So we're going to take our morning break, 15 minutes. Give you a chance to talk to some of our speakers, visit the exhibitors, and we'll be back in here at about 10:15 for our next portion of the morning.
And drive? Email, okay. Okay.
This. True.
Now it's 10:30. Stick for this. Stick for this. Thank you. So this is statistic. Okay. Alright. So the second one is person. Oh. Yeah, it's exactly. And it's central channel, so. Good, then this is. On the scales. Yeah, so. You. Okay. It's good. Cheers. This. The. Percent target. Yeah. Exactly. That's fine. Yeah. She's on her way. Just like. So. Whoops. Well, welcome back. Switch our program a little bit so to accommodate their delayed arrival. So it's my pleasure to welcome Boyan Niedeger to speak to us at this point about protein expression in human tumors, another microarray study.
Yes, good morning, everyone. My name is Florian Viehweger. I'm from the Institute of Pathology in Hamburg-Eppendorf. And maybe some of you have heard some TMA studies yesterday. Today, I want to talk about the protein expression. And the reason why we do a lot of prostate cancer research research at our institute is that we do have our Martini clinic at our medical center, and the Martini clinic is the clinic for prostate cancer with the most prostatectomies per year worldwide. So they do about 2,500 prostatectomies per year. So we do really have a lot of prostate cancer tissues, prostatectomies, biopsies, and here are the next bigger clinics with the prostatectomies, and so we do have really a lot of tissue from prostate cancer. Why protein? So prostate cancer can sometimes, especially in advanced stages or metastasized stages, can sometimes not be really good distinguished from other carcinomas, as you can see here. Here's some thyroid gland tumors in colon, or some lung or prostates, or it's sometimes just glandular structures. I mean, there are some hints to the different tumor types, but sometimes immunohistochemistry is necessary to us to confirm the diagnosis. If you know, there are some more prostate-specific markers for cancer, so PSA or PSAP or PSMA. So there are some more markers, and they do have a really good sensitivity and specificity. But sometimes in advanced stages, these markers get lost in prostate cancers. So we want to see if maybe protein is a good target for that. Or a good new marker. Protein expression is frequently retained in prostate cancer, so it was suggested to diagnostic prostatic marker. There are some papers. There are not a lot of studies for protein. There are just 23 hits in protein expression and PubMed so far. And here are some kind of other tumors that express proteins, or that are just data from the literature, so maybe some tumors of the testes as well as in colon cancer. And our material and methods are the same. We told yesterday we first want to do a very good validation of an antibody to compare with NR data from the or with some protein data from the human protein atlas, and then compare the antibody to a second antibody to get a good validated antibody, and to compare this antibody afterwards with all the tissue. And we do have here more than 15,000 tumors from more than 150 different tumor types. This is an this is from the protein atlas with the air expression data of protein. As you can see, for sure, prostate is a really is highly expressed protein, but there are some small marks in some other tissues. And the protein as well is an androgen regulated protein, which is preferentially expressed in prostate epithelium cells. That's like the same we showed yesterday. So we use a normal tissue array to look how the antibody works on a normal tissue, and to compare this with these data from the protein atlas if there is another staining or an aberrant staining which not fits into these data, and then compare this to a different antibody. And we used our MSVA antibody. We compared it here with another antibody, and we can see protein is like a granular cytoplasmatic staining. And we compared it here to another antibody and found out that here there is some expression as well as in stomach, as in the respiratory epithelium, as described before. Here, and there's some non-specific staining in the other antibody we use here, for example, in the placenta, or some small amount in the testes as well. And so we used these MSVA antibody and now started with our study with our hamburger tissue microarray program. So we do have all these tissued arrayed with lots of different tumor types, and our results of the protein expression in cancer tissues showed some expression for sure in the prostate, the cancer here, but there are some other peaks I will show you in the next slide. Here for sure the adenocarcinoma of the prostate as the top, but there are some others, for example, the neuroendocrine tumors in the lung as well showed some weak to moderate granular cytoplasmatic staining, as well as the salivary gland tumors or the arsenic cell carcinoma of the salivary gland, and as well as some carcinomas of the pancreas, so adenocarcinoma, and as well as some Kaposi sarcomas, angiosarcomas, so sarcomas as well, do a little bit of staining of protein. On the right-hand side, you can see classical staining of prostate, so the granular pattern, as well as in low-grade as in high-grade tumors of the prostate. And for example, here is some mucoepidermoid carcinoma of the salivary gland, as well showing some moderate granular staining. And here on the down right side, you can see the neuroendocrine tumor of the lung as well, showing some staining. So maybe protein is a little bit a misnomer. So we just showed that there are effectively some expressions of protein. Here you can see on the left-hand side some normal tissue. There is as well as some granular staining in the stomach, and there could be for sure some gastric adenocarcinoma of the intestinal type, who shows as well some granular expression of protein. And we found out some surprisingly protein expressions. For example, in spleen, you can see some granular staining at some macrophages, and as well as on the right-hand side in the giant cell tumor of the tendon sheath, you can find as well as some kind of granular staining in these bigger, like macrophages cells as well. And so our conclusion is that protein as well as PSA or PSMA is a highly sensitive prostate cancer marker, but it can also be expressed in various other tumor entities. So we concluded that a diagnostic of prostate cancer should also include some other markers if you've got some doubt where this tumor comes from, and maybe you should use a second antibody to confirm your diagnosis. And I thank you for your attention, and maybe you've got some questions.
Okay, some questions? So I'll ask one question. How do you think prostate compares to NKX 3.2?
That's
often touted as a very specific.
That's a really good specific new marker, or it's a good marker, and we didn't compare to NKX 3.1, but I guess NKX 3.1 is a more specific marker for prostate cancer than prostate, because prostate as I showed, did some weird staining at some other tissues, and maybe it's not the best marker for the prostate cancer. And NKX 3.1, we use it at our institute as well as a more specific prostate marker here.
Okay, thank you.
Thank you.
So our next speaker and a poster is Dr. Stephanie Warimu Karua.
Yeah.
So glad you've made it successfully, and you can pull your slides up here.
Hello. I hope you can hear me okay. I'm Stephanie Kahura, a Foundation Year 3 doctor in the Oxford Deanery in the UK, and I will be presenting a case about acute diffuse phlegmonous esophagitis, which is quite a rare medical phenomenon. So this is quite a scarcely reported disease, and it's defined by marked purulent inflammation of both the submucosal and muscularis layers of the esophagus. Our understanding of the pathophysiology behind this disease is quite vague because there are very few detailed cases of it thus far. It has a high mortality and morbidity rate, meaning that early diagnosis and quite aggressive management is necessary. Here I report the case of an elderly patient who presented initially with an array of quite non-specific constitutional symptoms prior to his diagnosis. So before we get into the case, I'd just like to talk about a few kind of etiological factors and complications of the condition. So a few predisposing factors include old age, diabetes, alcoholism, malnutrition, and immunosuppression. So a few complications caused by this disease include necrosis, esophageal stenosis, perforation, pleural effusion, and empyema, as well as metastatic involvement. So this is mainly diagnosed through computed tomography of the chest, abdomen, and pelvis. That's recommended as the first-line diagnostic investigation, which shows intramural circumferential low attenuation area of the esophagus surrounded by enhanced peripheral rim. So our case involves an 86-year-old gentleman who presented to his GP with essentially a 3-month history of rapid unintentional weight loss. He lost about 10 kilos in less than 2 months. He was mildly dysphagic to solids and had a recurrent dry cough as well as loose stools. He had a background of quite well-controlled hypertension. He had a full thickness infraspinatus and supraspinatus tear sort of 5 years before, and was a smoker with an 8-year pack history. He denied use of alcohol, but confirmed that he'd been having recent changes in his stools to type 6 on the Bristol stool chart. So initial blood work revealed anemia with moderate leukocytosis and neutrophilia, in addition to raised inflammatory markers. So his HB was 105, white cell count of 38.4, neutrophil count of 34.9, and ferritin of 1,037. On examination, there was really nothing to report back apart from a swollen left leg, which was suspicious for deep vein thrombosis. And for this reason, in addition to his deranged blood tests and kind of vague constitutional symptoms, he was referred to the same day emergency care unit of our hospital for an urgent review. So when seen in the emergency unit, he had a new a national early warning score of 0. So nothing to find on observations. He was in room air. Physical examination was sort of unremarkable apart from some lower leg edema. Following review, he was advised to stay in for admission onto the medical ward for further investigation, treatment, and clinical review, which he declined and was found to have the capacity to do so. He thereafter self-discharged against medical advice due to needing to return home to care for his wife, for whom he was the main caregiver. We gave him a stat dose of comoxiclav and a treatment dose of dalteparin in view of the suspicious DVT. He then was presented to the emergency unit about 8 hours later because of his worsening cough. So repeated blood tests and a computer tomography scan were done while he was in the A&E department, and they showed worsening inflammatory markers, and his CT scan as well was suspicious for acute diffuse phlegmonous esophagitis. So at the peak of his illness severity, his hemoglobin was 77, he had a white cell count of 110, neutrophils of 106, and a CRP of 202. His blood film showed neutrophilia with a left shift, no blasts were seen in his circulation. An ultrasound was done of his left leg in view of the suspicious deep vein thrombosis and only revealed a small Baker's cyst in his medial popliteal fossa, but no deep vein thrombosis. So we spoke to our microbiology team in view of his illness, and they advised to start on some tazocin and fluconazole, and we did start on some IV fluids as well, and then admit him to the gastroenterology ward for further review and management. So on admission, he was transfused with 1 unit of packed red blood cells and kept nil by mouth. A peripheral inserted central catheter was put in for parenteral nutrition and to support the long-term administration of fluids and antibiotics. We were advised to start initially on kind of a 3-week regime of the antibiotics and then sort of reassess and see where to go next. He was discussed with our wider tertiary Oxford team regarding EUS for drainage, but OGD was suggested as he was felt to have a mass rather than a collection. About a week after his admission, he developed severe and sudden respiratory distress. A chest X-ray done showed left pleural effusion that was quite extensive and hydropneumothorax as well. At this point, due to the worsening nature of his condition, it did not resuscitate. Form was filled out and agreed with him and his family. He was transferred to our respiratory colleagues for his chest strain under ultrasound guidance that was then that showed transudative fluid in nature. The scan done showed also moderate pericardial effusion, and a BNP level was done that came back 5 times the upper limit. So 2 days after his chest drain insertion, he developed a new oxygen requirement, needing up to 4 liters of oxygen via nasal cannula to maintain saturations above 94%. A repeat chest X-ray showed worsening consolidative rather than effusive changes, and he was then started on IV furosemide in light of progressive heart failure. He was seen to develop first detected atrial fibrillation that self-terminated within minutes, which was confirmed on monitoring and also an ECG as well. He had an OGD done that revealed a 5 centimeter mass in the lumen. He became hypoxic during this procedure, and only 2 cold biopsies were taken as a result. A repeat CT scan of his chest showed bilateral pleural effusion. So while we drained the left side, he now had a right side effusion as well. So a right-sided chest drain was inserted under ultrasound guidance. Here you can see the CT scan of his chest, abdomen, and pelvis, showing the thickening of the esophagus, which is approximately 15.5 centimeters in length. And then in figure 2, you can see his chest X-ray post his left-sided chest drain insertion. So there's no residual left-sided proeffusion, but there was now a new right-sided zone consolidation, middle and lower. So in conclusion, due to worsening oxygen requirement and work of breathing, the decision was made then to make our patient palliative, essentially. All observations were stopped and comfort medications prescribed. He succumbed to his illness within a few hours. The biopsies taken via OGD several days prior confirmed severely dysplastic squamous epithelium of the esophagus, implying malignancy. And a sort of a discussion point regarding this condition. So the exact causes in pathophysiology are not very well known, but it's clear that there's certain predisposing factors that do allow for the entry and growth of pathogenic organisms by altering the body's defense mechanisms. Our patient's only risk factor was his old age, although he was pre-diabetic at the time of diagnosis. It's unclear whether our patient would have benefited from surgical interventions such as drain and resection, as the mortality in such cases is about 50%. Given his frailty and old age, it probably would not have been a good idea to go down that route, hence why we did not. Early intense antibiotic therapy and parenteral nutrition are very important in long-term management. And the interventions that allow for brief stabilization of the patient while you try to figure out what next can be done. Due to the insidious nature of the illness, early intervention is key. Our patient had progressive symptoms over about 3 months, and no one investigated this up until the point that he needed hospital admission. Had it been done sooner, I wonder if his outcomes might have been slightly better.
There.
These are my references. Thank you very much for listening.
Thank you. So was an autopsy requested on his patient?
No, it wasn't. The family declined. So
So requested at this point.
yes.
Yeah, just
Yes.
yeah, you mentioned that the pathology showed malignancy. What's the
Yes.
relationship between malignancy and this condition? Is there any relationship?
Yes, so there's very few cases reported. I found a few that did show progression into malignancy in later stages, because this patient did have an OGD prior that was and had a few biopsies taken at the time that did not show malignancy. So I wonder that as his disease progressed, this proliferation then happened. Any other questions? Thank you.
Great. Thank you. So pleased now to have an exhibitor presentation by Maja Joswiak and Pietro Giusti. How to change the slides? Oh, that did it. Yeah, you touch it. So you just touch it. My name is Artur Olszewski. I am CEO of Alcity company. We'd like to present our program, which is a program for automatic diagnostic for bioinformatic tool to automate the diagnostic of bladder center cytology. Is our research program donated by EU and Polish National Research Center. And I would like to give a voice our main researchers to present our AI system to give the automatic diagnostic. Please, Maya, come.
Hello, everyone. My name is Maya, and I will present the medical part of the presentation. So the project goal was to develop a tool to assist the cytologists in analyzing urine sediments, cytology specimens. This project was implemented under the competition, and the duration of this project was around 1 year. So we are in the further development. So we will just present the first part of the project. Okay, so firstly, I'll talk a little bit about urinary tract cancer, which is ranked 6th in frequency among malignant tumors in developed countries. The study faced limitations, partly due to the requirement of delivering fresh urine to the laboratory, and another constraint is accessibility to laboratories conducting cytological examination. So we use the PARIS system for reporting urinary cytology. This system, I hope, is mostly common for doctors. It is a system primary task with standardizing microscopic evaluation principles and developing clear unified criteria for cytological diagnosis, which are understandable to clinicians. We mostly focused on the two categories in this Paris system: the suspicious for high-grade urothelial carcinoma and positive, because those two types has the most sensitivity to finding the illness. So the Paris system assessment criteria include the nuclear cytoplasmic ratio, degree of nuclear hyperchromasia, the degree and type of nuclear chromatin clumping, presence of nuclei, nuclear membrane outlines, and the presence of necrosis. And essential assessment was the quantity of altered cells in the specimen. As I said before, we only focused on the suspicious and positive for high-grade urothelial carcinoma. Data set. We gathered a database of 5,000 preparations from many labs. Those preparations were all anonymized. We used three scanners, Hamamatsu, OperaScan, and Leica. We saved those scans in native formats, and we also scanned the descriptions of diagnosis in natural language, and then we converted it into the special program and put it into tables. So every sample had their diagnosis, so we knew what we were working on. Data processing. As I said before, we had diagnosis in natural language. The diagnoses were excluded according to the Paris classification. Then after the scanning and the diagnosis, we did a tiling process, which cut to the smaller pieces a whole sample. After that, we had some issues with the scans, so we needed to conclude like brightening process. After that, we used data. We did annotating with the data set with special cytopathologists and doctors, and the last part was to train the models. So tiling, as we can see in these pictures, that this is the whole sample on the right, and we use special semi-automated algorithm to cut to smaller pieces the whole sample, because we didn't use the part of the sample that was blank, as you can see on the left picture. We cut it to the size of, as you can see in the bottom. It is because the size is very unusual, but it is because it matches our monitor that we were working on. It also helped to simultaneously work for a few people on one sample, so the work was faster, and it was more comfortable to look on the small square than on the whole sample. Then CVAT is an open source program. It is not medical, but it helped us to work. We divided it to tasks, jobs. Task represented the tiles. From one scan, job was a subset of maximum of 100 tiles. So, for example, one person had a task of 100 tiles, and they did the jobs on each one of them. On one tile, an annotator viewed and described cells. Yes, so that's the CVAT application. Annotation. As I said before, we mostly focus on the high-grade and suspicious for high-grade urothelial carcinoma. We also added one more category, which was edge, because when we were tiling those specimens, we had a problem that some cells were in the middle of an edge. So half cell was in the one tile and the other one was in the second. So we used this category to mark the cells that were like in this position. And then when clinicians mark those cells, the program generated more tiles that the cells were in the middle of the tile, so they can annotate it properly. And after that, we aggregated those in one specimen again. So we had the whole specimen corrected and matched. So thank you. I'll give voice to my colleague.
Thank you. I would like to continue about augmentation process because the data set was good, but not enough. It's better to have a lot of data, different categories. So that's why we augmentate data sets. And for this, we use GN models to extend the data set, and then use synthetic images, segment anything models from Facebook to make segmentation of this. But also we test and use Euro models. It's open source models to make segmentation and classification. Mainly in this process, in this goals, we do classification because we have to make a class. We have to classify nuclei and cytoplasm in the cells. And then we also check the parameters about the size of cells and accuracy of nuclei and cytoplasm segmentation. This we use parametric models. And here you can see the examples of how the segmentation process looks like, because we are during the project yet, as we not finished yet. We first goal was to make good quality segmentation of nuclei and cytoplasm and whole cells, and then check the ratio between nucleus and cytoplasm together. So for this, because it's important for and diagnosis and this classify of atopia or not. So and this slide shows how the process and average models look like of different stories of segmentation and accuracy of these models and histogram. And at the end, we use Papa AI Uro Wix desktop application, which help us to show result of the models of the current step of the text, and we use this desktop application to show to medical advisors the result of job and in the future on the end customers. But also we want to implement and integrate future end project end models on the platform, Cancer Center AI platform, which we show today and tomorrow on this conference on our booth, the end of this room. And on this platform, it also other models like cervical cancer detection or Gleason score models. So we work to add every new models there. We also we saw that not so many pathologists department use scanners. Many of them use microscopy, and for them we also develop manual whole slide imaging software to support digitalization process from microscope and cameras, microscope cameras, and so you can see it, how it works. Yeah, we can show you on our booth. But it's very helpful for also urgent cases during surgery to speed up digitalization, and more cheaper than scanners. And here is the result, for example, of our viewers, how we can show the different stains, the same tissue in the viewers, and result of the Gleason score, for example, on the tissue, on the slides. So thank you for your attention. If you have any questions, feel free to ask.
Any questions for our exhibitors? So thank you. Yeah, since your certificates of achievement there.
Yeah.
Very easy. Nice. Oh, no, it's just. That's the. So we will move forward. Our next speaker is Dr. Dalia Al-Sadiq Mohammed Hussein. She's from the Oral Pathology Department of Dentistry, Al-Nilain University, and she's going to speak to us about identification and care of oral cancer stem cell among Sudanese patients.
Where I can find. So I couldn't find a presentation. It's not. No, it's not. This is the one. No, this is not.
No, this is the previous one.
The previous
I'm sorry.
Sorry.
Yeah.
Dalia.
There we are.
Yes. Thank you. Thank you, a lot. So, hello everyone. I'm Dr. Dalia. I'm from Sudan. Basically, I'm an orthodontist. Recently, I obtained the position or status of diploma in the American Board of Dental Regenerative Medicine. So I'm interested in area of stem cell, as you could notice. I'm going to present my ongoing research back home. It's under the title of Identification and Characterization of Cancer Stem Cell Markers in Oral Squamous Cell Carcinoma among Sudanese patients. So oral cancer is a malignant neoplasm affecting any region of the oral cavity, pharyngeal region, and salivary glands. Oral squamous cell carcinoma. When we say oral cancer, also we use this term in synonymous with oral squamous cell carcinoma. It's representing the most common variant of all oral malignancies with more than 90%. Oral cancer is one of 6 most common types of cancer. The incidence is 300,000 cases worldwide, representing a global health challenge due to its impact, unpredictable behavior, and high level of mortality and morbidity. The oral cancer in Sudan comprised 12.6% of all cancer registered between year of 2012 and 2016, revealed that
1,000 and more cases recorded. And the patients are more likely to be males with a percentage of 59% and female with 40%. Elderly patients tend to be more commonly affected with oral squamous cell carcinoma. The etiology and risk factor of oral squamous cell carcinoma are tobacco and alcohol consumption in synergistic effect, infections with human papillomavirus, for example, like HPV type 16, as listed in the literature, usage of betel quid and nitrosamine-rich food, nutritional deficiencies beside genetic factors. Genetic damage include inactivation of tumor suppressor genes, inhibition of cell proliferation, end up with cell dysregulation, growth become autonomous and invasive mechanism, along with angiogenesis. Clinical features of oral squamous cell carcinoma. Sorry, the pictures may be a little disturbing. Patients are coming to the clinic complaining of huge tumors, fungated with the ulceration and so on. Also, this is caused tooth or teeth loosening. And if you perform an X-ray, you will find change in the underneath bone. Squamous cell carcinoma, it's graded 1, 2, and 3. Under the microscope will be projected as well, moderate and poorly differentiated respectively. Clinical staging of oral squamous cell carcinoma is based on the T and M system. T refers for the size of the tumor, regional lymph node stated as N, the development of distal metastasis term M. The T and M system is primarily used to design the treatment approach for the oral squamous cell carcinoma, that is to say locoregional tumors often are cured by surgical resection. However, upon diagnosis, several tumors are already locally advanced stage, lead to poor diagnosis despite multinodal treatment option, including surgery, chemo, and radiotherapy. So what is about the interesting term cancer stem cells? Cancer stem cells are highly tumorigenic, capable of self-renewal, have the ability to differentiate into cells, constitute the bulk of the tumor. The cancer stem cells are resistant to conventional therapy. They are initiators of local recurrence and metastatic spread of oral squamous cell carcinoma. The normal basal stem cell are considered, that is to say, normal basal stem cell are considered as a starting point for malignant transformation in oral carcinogenesis and the keys of the genetic, phenotypic, and physiological alterations. Stem cells located in the oral epithelium acquire genetic alteration, produce daughter cell expand, and showing distinct morphological features such as leukoplakia, which is the white discoloration, and erythroplakia, which is the red discoloration. The ideal markers of cancer stem cells should disclose the featured sign of self-sufficiency, anchorage-independent growth, apoptosis or drug resistance, invasion, metastatic potentiality, beside self-renewal activity achieved by the cell of origin. Oral cancer stem cell markers in oral squamous cell carcinoma. Several putative cancer stem cells, such as CD44, CD133, CD24, LDH, nestin, and NANOG, are suggested to act as indicators of tumor cell population with enhanced tumorigenic potential and reduce the sensitivity to chemo or radiotherapy. So what about the previous studies? There's a study reported that CD133 tumors positive are more tumorigenic than the CD133 negative ones. Moreover, CD133 positive cells showed higher chemotherapeutic resistance to the drug called cisplatin and vigorous self-renewal ability, suggested the potentiality of CD133 positive cells to be responsible of oral squamous cell carcinoma aggressiveness. Also, there is another study revealed that expression of transcriptional factors OCT4, SOX2, and NANOG was also associated with the cancer stem cell in oral squamous cell carcinoma, but due to the enrichment approach, there is instead used for characterization of putative cancer stem cell population by receptor gene assay or for analysis of cancer stem cell by immune histo or cytochemistry. Many studies reviewed the presence of cancer stem cell in moderately differentiated squamous cell carcinoma of the tongue. They reported the presence of embryonic stem cells, OX2, OCT4, and other with cancer stem cell marker CD44. So what are our objectives to enhance or to maybe perform the study? Our objective, the general objective, to identify the oral cancer stem cell markers, CD24, CD44, CD133, NANOG and nystatin. That's why nystatin, sorry, they are repetitively shown in the literature, and their association with clinical and histopathological parameters of oral squamous cell carcinoma. The specific objective were to determine the expression of CD44, CD24, and the other in tissue and blood, to compare the expression of these markers between tissue and blood, to correlate the presence of cancer stem cell markers with the clinical data of the patient, which are age, gender, habits, and risk factor, along with the staging of the tumor itself, to figure out the association between the expression of cancer stem cell marker status and the following tumor parameters. The tumor parameters are tumor progression, aggression, local regional, and or distant metastasis. To add a new diagnostic technology may be approached regarding stem cell marker identification or squamous cell carcinoma to validate the blood sample as a screening and predicting diagnostic tool. Our material, this study will be descriptive cross-sectional hospital-based study. It will be conducted as joint project and supervision at the Nilan University, Nilan Stem Cell Center in Khartoum, and Faculty of Dentistry and Transitional Center Tissue Engineering Group at Bergen University, Norway. Cases will be recruited by non-random selection method from Khartoum Dental Teaching Hospital in the Department of Oral and Maxillofacial Surgery in Khartoum State, Sudan. Data will be conducted through direct will design questionnaire involving age, gender, occupation, clinical data, residence, duration of the disease, treatment protocol, and previous investigations. This is our calculation of sample size and inclusion criteria. Inclusion criteria will be also the niche patient cell carcinoma. Our method was sample collection. 200 tissue sample will be collected as excisional biopsy after the confirmation of initial diagnosis and to be accompanied by 3 ml of erythra blood. Tissue sample will be collected and divided into two specimens. One specimen in solution for histopathological diagnosis confirmation, which will be performed by 2 different specialists in the oral pathology laboratory in Khartoum also. The other tissue specimen will be stored at -80 in cryotype cryo tube containing RNA later for molecular analysis. On the other hand, the erythra blood sample will be separated for mononuclear cell isolation for flow cytometry and polymerase TR that will be accompanied by identification of the cancer stem cells by flow data interpretation. I hope in the next version of the UCG, I will present the final result for you. Finally, those are my 3 heroes, my kids. Thank you all for your listening. If there is any question, I will be.
Any questions? The same.
Thank you.
So at this point, we'd like to invite to return to the stage Dr. Barzak and Jaroslav Britain to talk to us a little bit further about the use of their AI tool for how we transform clinical pathology into digital pathology. Studies from the pathology department at Zakopane, Poland.
Okay, hello, ladies and gentlemen. My name is Jarosław Kwiecień. I am the CTO of Cancer Center AI, which is a Polish company founded to support cancer diagnosis by applying computer science, including AI. And with me is Artur Barczak. I'm a pathologist from Poland, from Zakopane. Yesterday we presented our research project about prostate cancer diagnosis with AI. Today we want to present a more practical solution which is already working. It's well tested. We'll be talking about how we helped the Department of Digital Pathology in Polish hospital in Zakopane to transform from clinical microscope diagnosis into fully digital diagnosis process. Yes, I see that Dr. Artur forgot something probably, but he'll in a moment tell a little bit about his pathology department. Okay. Okay. I live in Poland, in Zakopane. It's the city in mountain district. So unlucky, I'm the only pathologist in the city. So starting from February this year, I've decided to shift to digital pathology because I need a second opinion. I need also to move sometimes for vacation like today. Actually, I'm here and still I'm diagnosing virtually. So I'd like to share with you some thoughts about how I shift from standard pathology into new era pathology. So first of all, I'm lucky because I live in beautiful place and it's a mountain district, so it's nice, so I can relax after all. And I'm also lucky because in Poland there is no regulation about the digital pathology. Actually, I'm one of the person who is some kind of building this regulation based of Polish Society of Pathology. So we are in course of preparing for somehow of standardization in digital pathology. So we use different scanners in our department, but finally we've decided to use Olympus VS 200. This hardware has different objectives, so it's nice that we can see very small pieces and bacteria even on site, and we use 35 slide plates. The capacity is, as you see, 35 plates per with 6 slides on each, so it gives me 210 slides. We have also a scanner reader inside the scanner that we can read the data matrix got on each slide. As I mentioned before, we started with digitalization from February 2023, and all slides that is in our department is going now through the scanner. We have an amount about 2,000 slides per month, and routinely we use smears, cytoblogs, and tissue. How we prepare everything. So the flow is from the lab mode. We use slide preparation, and on each slide we stick data matrix barcode that it's coming from the list system. We digitize on the slides with objective 20. We use 40 if we would like to see the HER2 using with chromogreen in situ hybridization for breast cancer, because we use chromogranin in situ hybridization, not immunohistochemistry. And we use batch scanning template without Z-line. There is also a tissue recognition. And finally, we obtain VSC format. It's typical format for Olympus, which is stored with data matrix code name.
Okay, and then goes the part where we were more responsible for preparing for setting up the process. So once the slides are scanned, there's a local server for uploading the slides to our cloud system. It is synchronized every 60 seconds. It generates file names based on the data matrix code with case ID and stain. And then the slides are grouped by case ID automatically and put into the system which manages the cases, which allows also tracking the status of each case. And Dr. Arthur will explain more about this.
Our lab personnel is obligatory to change the proper status. So as you can see in our lab, we use cytoblogs plus argent. So it means that in this catalog, there should be diagnosed firstly. There we have a regular procedure and FNA thyroid, because also in our lab, we perform FNA in thyroid. Okay, as a pathologist, I have two monitors with extended view. One is for LIS and with personalized data of the patient. And second one is for Patho Viewer, where we have anonymized slides. Data matrix code, as I mentioned before, connects LIS with Cancer Center AI. So in final, we can perform, after all, final report which is coming from the list, or just perform or set extra tests, like ancillary studies, for example, extra immunohistochemistry or histochemistry, or NGS, for example, which we have also in our laboratory. And so I'm changing status of the case to the proper one. If we'd like to perform additional tests, I'm changing the status to during immunohistochemistry or during consultation for second opinion, that I can choose the consultant and he will obtain this slide, particularly this slide that I want him to consult. Or if the case is ready and it's in prediction progress, like I mentioned before, like for NGS. And one of the catalog is also archived for education purpose in the future, if you'd like to use it. And then we need to perform extra digitalization if we obtain the extra tests, and then I write final report, and I can trash the case from the pathology view. Based on Ministry of Health regulation, because we have such, there is obligatory to store for 20 years paraffin blocks and glass slides. So it's in archive. Of course, on demand, I can ask for a rescan each slide if I would like in the future. This is our scanner. As you can see, it's fully automated. So this column on the right, you can see it's robotics that can push the tray with slides to this on the left small hardware, where is actually there is the scanner. These trays look like this. So the nice idea of this scanner, because I many times I'm try to find a good purpose, the good solution for my purpose. So I've decided to use trays because especially if I have a frozen section during intraoperative, and the small glasses that I put on the big glass, sometimes it's still sticky, so it can be a problem if we don't use just like a solid state where I can put the correct slides. So I've chosen this hardware. Okay, as you can see, there is a 35 plates like this. On each I can put 6 slides. Okay, and this fully automated process, I can choose which slides can be scanned with 20 times objective, or which one should be used template for 40 times objective, like for HIR2 in breast cancer. So it's fully anonymized. As you can see, there is a sticker, there is a number that can correlate with the patient in the list system. So with this slide, as you can see, this is the same patient. There are different blocks with number of this block. It's third. This one I could pointed. This one is pointed. It's third block. It's nice that the system can group together all the slides based on the barcode and put it inside one catalog. So I have a case in one catalog with, for example, 35 or 40 slides inside. It's cytoblocks, as you can see. It's not maybe good to see in this way because there is a monitor that shows differences that I have online. But still, as you can see, there are cytoblocks. Probably there is a pleural fusion. It's from lung cancer, adenocarcinoma. The patho viewer can give me also the possibility to perform some measurements. Like you can see, there is a roller. It's nice because it's some kind of combine, as Yaroslav can mention about this more maybe. It's combined with the point how zoom this slide is. It's actually automatically changes the ruler size. This is nice also for the performing analysis of mitosis to perform counting of mitosis in square millimeters. So as you know, in WHO, there are so many countries that so many cancers that we need to count such mitosis per square meters, and that patho viewer team decided to put it inside the software.
Okay, it's your turn.
Okay, so Dr. Arthur presented what it looks like from his perspective of the user of the system. Now I will briefly.
I would like to add something.
Oh,
This is the nice gadget that I obtained. I took it from my kids now. So there is no mouse anymore. I like it very much because I can work with this. It's from Xbox and with joystick, and I can perform all analysis with this. So nice.
yeah. So I would like to tell a little bit about the technical side of this integration. So this lab in Zakopane is relatively small. There are about 2,000 scans per month. So we decided to make to go to the with the cloud version. Yeah, and there are many benefits of cloud versions. So basically, it is much easier to manage, to update, to quickly provide new features, implement new features from our side. It's also scalable in terms of usage. We can easily manage the servers to automatically scale based on the demand. The storage is scalable without any limits. You don't need to worry that you will run out of disk space because your scans are too big to fit in the hardware that you have bought. And also, it's very easily to quickly share the slides for consultation to any person. It's quickly accessible from everywhere. Uh, yes, and there are, of course, there are some issues, some questions about cloud version, and probably the one of the biggest concern is the latency. So when the slide is scanned, it needs to be uploaded to the cloud, and of course, it takes some time. Sometimes we can't wait that much to wait for the scan to be uploaded, for example, for intraoperations diagnosis. So when we have this workflow that the scanner, it saves the scan on a local PC and then it is uploaded to the cloud so the user can view it. Sometimes it's too long, so we have worked to also make a solution which will simplify this workflow in cases when we need quick access. So during the time when the scan is uploaded to the cloud, it is also possible to view the slides directly from the local PC in the laboratory. You are still using your computer in any place in the world, but there is a small additional server working in the laboratory, which serves the already scanned slides on demand. It has its limitations. Maybe it's not as fast as the cloud version, as the slides which are fully uploaded to the cloud. Maybe it is limited to a few users rather than hundreds of users, but it is enough to serve files for the time of the process of uploading to the cloud, and it is totally seamless for a user. So the user just opens the slide and he doesn't care if it is already in the cloud or it is local. There will be maybe a little bit slower viewer when it is local, but it is only for the time of uploading to the cloud. So I think that was quite interesting feature which enabled us to successfully integrate the cloud version for this pathology department. Yeah, we have also implemented a few automations to make cases and slide management easier, faster, more convenient. As we said before, the cases are grouped by the scans are grouped by case ID automatically, and then you can view all the slides for one case, assign the person who will be responsible for the diagnosis. You can track the status of the cases. And there are other benefits of digitalization. One of them was mentioned yesterday, that it enables us to use AI for automatic calculation of some features, for example, Gleason score on the slides. Also enables the pathologist to easily compare different stains of a tissue. Here we have example when we have the same tissue scanned with hematoxin and eosin on the left and CK-pan TTF1 on the right, and you can view them in parallel. You can easily compare the same region of the tissue in two stains. Yes, and we have plans to add new features to our system in 2024. We'll be working on our integrated limbs so that there will be no longer need to work in two separate systems. We'll be working on voice assistant to enable filling reports by voice and navigate the system, so keyboards will not be needed anymore for any work with the system. And we want to introduce more AI algorithms into diagnostic process and integrate not only as now we are currently finishing research projects and we are still working on this to be ready to use in a clinical way, but also we'll be working on integrated AI algorithms from other providers. Some of them are already certified to work with. Yeah, and we spent really a lot of time to make the system easy to use, fast, and more and quite practical. And we have a lot of positive feedback from our users. Yes, one of them is Dr. Arthur Hugh. So the final question is should we perform digitalization or maybe working with microscopes is better for a pathologist? And there are, of course, different aspects to consider. One of them is that maybe the most important factor is diagnosis accuracy, but there are several papers which compare the accuracy of diagnostic performed with a microscope and in the digital way, and there are no significant differences in the accuracy. Of course, the other aspect is cost of equipment. Usually, the scanner is the most important part of of the cost, and yes, it's quite a huge problem, maybe for small laboratories, and for them we have also another solution called PathoCam, which enables to scan the slides using only a microscope and a camera which is attached to the microscope, and then by just manually moving the slide, it can be the entire slide can be scanned in a few minutes usually. Yes, it's an alternative to a scanner, which is maybe a little bit less convenient, but a lot cheaper. Yes, and of course, the last thing to consider is, and maybe the most controversial one is, does it speed up the workflow in the laboratory or not? And actually, the results measured in the papers are quite mixed. Some papers indicate that digital pathology is more effective, and others indicate that it is the opposite way. And I think the key factor is to do it well, to do it in a way which integrates into all digital all laboratory workflow, not only the viewer, but all the integrations are important here. The user interface is quite important. That's why we are working on a lot of small improvements, like this gamepad integration that Dr. Arthur showed. Yes, so digitalization is not easy process. It's there are many aspects to consider, but this process that we have done in this laboratory in Zakopane, during this process we learned a lot how to do it efficiently. Yes, and that's all from our side. If you have any questions, feel free to ask. Thank you for your attention.
Do you have any questions? I have a couple of questions for you, Dr. Bartek. How many personnel did you have to add to your laboratory or take away from your laboratory when you moved to digitization? So have the number of workers in your histology laboratory changed?
No, completely not. We have 8 people on site, and I'm the only pathologist. So
And so the histotechnologists as such have taken on the additional work of digitizing the slides without complaint.
it's the normal, usual stuff that they do.
And did you have to change your histology processes in any other way or give instructions so that your slides were more ready for digitization?
No, exactly the same.
Wow. That's remarkable because many histology laboratories find waves or placement of the slides and straight tissue is a problem for them that they need to fix first before they go digital. Other questions?
So you mentioned that the slide is sticky, right, on the tray. How did you solve that?
Oh, it's not a problem. As you see, there is a plate, yes, solid plate.
Right.
With other system like I used to have in my laboratory, it was like a Leica, for example, that there was such a robotic arm that just pushed the one slide, and sometimes the cover on it can move, so it stick inside. So when we would like to put, for example, 200 or even more slides, it stick on this one, and during the night, no more slides were scanned. And with this one, it's like just everything is putting, so you have fixed everything on plate. There is just camera that's scanning moving all the plate with the scan, so it's better. And if sometimes when you cannot zoom exactly, to try to find another solution, so maybe it's like 2 times, even 3 times to rescan this area, and then can continue. If it doesn't, it doesn't succeed, it can continue with other slides. So I need to rescan only this one or change something after night.
And when you copy it from the lab information system, how do you launch it? Do you copy the accession case? How do you open the case digitally? You have your lab information system, MTLIS.
I made it by myself, this lab. Please.
You search for those cases?
No, it's just like till now, because there are separate systems, yes?
They are separate.
Separate. So the only idea is that I need to copy the barcode, because in barcode there is a code that can be recognized in our list. So I copy the code and just open exactly this case after copy it.
Yeah, but copy paste sometimes, like, you might be susceptible to mistakes, right? If you copy and paste, always when you copy and paste, it's like, why didn't think about integrate?
Yes, we are thinking about this. This one, the previous slides, yes, it was like built integrated limbs with VSC.
Yeah, but that was time.
No, don't think so. Building limb, it took me 4 years.
Okay. Okay. All right. So our next speaker is Dr. Bahara Arbabi. glad to have you with us. She's going to speak to us about the effect of DVD plasma therapy on wound healing after labiaplasty. Let's see, help to get this up here. It's just.
Hello, everyone. Hello, everyone. Let me introduce myself. This is Dr. Bahar Arbabi, OBGYN, cosmetic surgeon from Iran. I've been working in this field for 12 years, and it's my great pleasure to be here today to talk to you about the effect of DVD plasma on wound healing after labiaplasty. At first, I jumped to labiaplasty. Labiaplasty is designed to reduce the size of labia minora. Women opt labiaplasty for a variety of reasons, including pain from twisting or tugging of labia when they're riding a bike or during intercourse, itching, irritation, and self-confidence. Labiaplasty may be performed to reduce the size of labia minora and reduce asymmetry when one is longer than the other, or more commonly to reduce the length of both labia so that the labia no longer cause discomfort or fall out of the bathing suit. There are several techniques for labiaplasty that are edge resection, wedge resection, deepthelialization, extended W-plasty incision, laser labiaplasty, and labiaplasty with calytral hood reduction. The most common type of labiaplasty is trim because in this procedure, extra tissue is removed and sewn up directly because this technique is easiest to perform. There are some disadvantages, including the loss of natural rugosity or wrinkles of the labia minora, and thus aesthetically, it produces unnatural appearance to the labia and vulva, and also present a greater risk of damaging to pertinent nerve ending. Another procedure for labiaplasty is wedge resection that aesthetically it prefers to edge resection because it preserves the natural rugosity of labia, and central wedge resection can treat prominent calytral hood without a separate incision. Some disadvantages of this procedure are very demanding surgical procedure and increased risk of wound dehiscence. There are possible risk of labiaplasty complications related to anesthesia, bleeding or hematoma, infection, poor scar, reduced or increased sensitivity, asymmetry, over-resection, or pain during intercourse. And in addition, some of common complications include redness, swelling, itching, and discharge, and especially dehiscence after labiaplasty, which are often annoying. It's important for all surgeons to control complications. And what is DVD plasma? Dielectric barrier discharge. Plasma medicine is only about 2 decades old, but the research community activity in this emerging field has grown tremendously in the last few years. Today, research is being conducted on a number of applications, including wound healing and cancer treatment. And this is research at the intersection of physics, engineering, biology, and medicine. This is a timeline showing some major milestones of a new field of biomedical applications of low temperature plasma. And you can see first decade early foundation of plasma medicine from 1996 to 2006, and the second decade rapid growth of plasma medicine until 2013 in many countries like Germany, Japan, USA, and Europe, and Asia. The main low-temperature plasma device used in plasma medicine research are the dielectric barrier discharge, or DBD, and non-equilibrium atmospheric pressure plasma jets. In fact, the DBD uses plate electrodes covered by a dielectric such as glass. Gases such helium with admixture of oxygen or air are usually used. Plasma is created when enough voltage is supplied between electrodes, and the plasma is generated in the gap separating the electrodes by the application of high sinusoidal voltage in kilohertz frequency range. Plasma therapy is a typical non-equilibrium high-pressure gas discharge, which can be a less complicated and safe method in controlling skin complication and accelerating wound healing. Plasma can be seen in daily life as lightning in thunderstorm or northern light or neon light, and it can be ignited at low or atmospheric pressure by adding energy to a gas like air, argon, or helium. This is some effects of DBD on wound healing, stimulating of proliferation and migration of wound-related skin cells, pro-angiogenic effect, and monocyte stimulation, keratinocyte proliferation, and increasing cutaneous microcirculation. Marked germ reduction on wound and accelerated wound healing have already been convincingly demonstrated in controlled clinical studies. Let me show you a short video about the effect of cold plasma on wounds. Sorry, something is going wrong because the sound is not enough loud. No. DVD plasma therapy was used in the present study for patients underwent labioplasty during 1 year ago in my office, and its effect of the mentioned complication was investigated. These are the study questions. How many patients underwent labioplasty have wound redness? How many had wound secretion, feeling of itching, and dehiscence after DVD plasma therapy? In this experimental study, 40 patients aged 30 to 40 who had undergone labioplasty were recruited. None of participants had medical history of smoking or medications, and DVD plasma therapy was performed on the 3, 7, and 10 days after surgery, because we have 3 stages of wound healing, and in the second stage that start from the 4th day after surgery, we have the load of bacteria on the wound and the high risk of wound infection. And this is the reason we decided to start DVD plasma on 3 and 7 and 10 days after surgery. Each session lasted for 10 minutes, and after the procedure, the operation site was assessed for redness, secretion, and itching on 7 and 14 days after surgery, and the wound was being reassessed for dehiscence until day 21. Following the DVD plasma therapy that started on the 3 day after surgery and was repeated on the 7 and 10 days, the wound assessment on 7 stage showed 2.5% of the wounds, women's wound had high level of secretion, 20% had moderate level of secretion, and 77% had low secretion. And on the 14th day after surgery, these values reached 0 and 5 and 95% respectively, and these changes were statistically significant. You can see the graph here. And these are some related articles about the effect of cold plasma on wound healing. This is a kind of study in 2021 about the effect of cold plasma that improve cutaneous microcirculation in acute wounds. This is another about the effect of cold plasma that improves microcirculation parameter in chronic wounds. And the effect of cold plasma for treatments of acute and chronic wounds also. An application of cold plasma in dermatology, antibacterial and safety test of flexible cold plasma device of the stimulation of wound healing. And these are some pictures about my own patient that underwent labioplasty. You can see in some rare cases, we have a kind of secretion or redness in a small amount of part of wound. And after using DVD plasma, we can see a kind of contraction in the wound, and the satisfaction of our patients really were wonderful. And, because I'm obstetricians also, and I have many pregnant women, and sometimes after cesarean section or natural vaginal delivery, they come back to my office and we feel something is going wrong, and we can see a kind of secretion or redness in a small part of the wound. And after using 3 sessions of DVD plasma, sometimes my patient called me back and they said, "Come on, doctor, tell us, what did you do? We really feel comfortable after using DVD plasma." And when I reassess the wound after 1 week, I can see the result that is really wonderful. Yeah, and I think it's necessary for all doctors to have a kind of cold plasma device in their office, because this is not very expensive device. It's cost effective and cost benefit for both patient and doctors, just around $1,000. And maybe in future, we will find this kind of cold plasma in all markets, and we can use it instead of iodine for sterilization the wound. Thank you for your time.
We have any questions for Dr. Alba? So I can't ask any really intelligent questions here, but I would ask you one question, and that is, has this been applied with things like wound infections in more serious situations like gynecologic cancers and so forth, where wound infection can really set them back in terms of treatment?
Yeah, we can use DBD plasma in all kind of infection, in wound infection, and the last slide that I just show you, this is a kind of wound dehiscence after hysterectomy that was the patient, because the patient was immunocompromised, and we can use cold plasma. And after 3 sessions of cold plasma, you can see kind of contraction in the skin and in the wound. And we can use in all kind of surgery, gynecology, cancer, and maybe in future we will use cold plasma in cancer treatments also, and in food industry sterilization also. This is some matters that need more research, I think, and it's not clear now. Yeah.
At this point, we'd like to invite back to the podium Isaac Jowiak and Peter Krajewski to talk to us about further about their bioinformatics tool to automate the diagnosis of breast cancer.
Hello, my name is Artur Olszewski. I am CEO of Alcid company from Poland. I would like to introduce our research program about doing AI tools to giving automatic diagnostic for histopathology of breast cancer. And I would like to introduce our main researchers to present our program and system. Please, may I come?
Hello. So as before, the project is implemented under the competition Infrastratec. It is a national competition, and we are currently implementing stage 2, and the duration of the project is 3 years. So a little bit about breast cancer. Breast cancer is the most malignant tumor in women and the second leading cause of cancer-related deaths among female oncology patients in Poland. As we know, the breast cancer is not a singular disease, so there are different tumors and we need to verify them. The system classifies analyzed cases according to the TNM staging system. We have samples from fine needle aspiration biopsy and postoperative excisions. We did use different staining methods like HE, the basic one, and immunohistochemistry. We acquired and annotated data that we perceived. Also, as in the project before, we analyzed the natural language and converted it into the tables. While working on this project, we decided to work on the tissue detection and the cell nuclei detection because it's very important to diagnose the type of the breast cancer. Scanning. So as before, we used different scanners. UltraScan and Hamamatsu were our primary ones. We had some issues with scanning. So the first one was the sample preparations. Some of the samples had marker notes on them. Sometimes the knives that were cutting the samples were blunt, so the tissue was torn. And sometimes the thickness of the scans was like too thick, so we couldn't work on it. The second thing about scanners, as we can see on the last picture, it is that some scanners scan differently, and we needed algorithm for selecting sharpnesses and to make the images quality the same from different scanners. So we had some local or segmental losses of sharpness differentiating between the scanners. Sometimes we had also artifacts that were related to image stitching. So that's it. So we needed to make a conversion to DICOM. You may ask why, but it was one of the requirements of the infrastructure competition. It is not common to use DICOM in histopathology, but mostly in CT or MRI. In this picture, we can see a sample on the left, the whole sample, and we used some masks to cut it into the smaller samples, like here on the right. So the primary goal of the creators of the standard was to standardize the exchange of and interpretation of diagnostic images. So when we had a sample, it was an image and the diagnosis in the natural language. Database. This was our application to go through the samples, and as you can see here, there is like one patient with for here this patient had 2 samples, and we can see in this staining we could choose between stainings. It is showed here. So we could like different we could choose between different staining, but it was like a huge database but it was very clear for the diagnosis and clinicians. Yes, you can see it better here. Everything is in the natural language. The diagnosis is in the natural language, and there are also images with different stainings. Annotating process. So as I said in the beginning, we did use 2 different annotating processes. First one was to annotate the nuclei, and the second one was to detect the tissue and how the tissue is laid down in the preparation. And we had a dedicated tool for it, and it was marked by clinicians and diagnostics.
Okay, as Maya said, we are during the project. So first step was build the database. Second is annotation process. So right now we are doing this step, and we want to support this process by AI also, because it will help for clinicians to do it faster. So first goals was annotate tissue, not analyze whole slide, because there is a lot of white space. We don't have to analyze this. So it's the goals is to make segmentation of the tissue, and then focus on cells and try to find nuclei and cells, because for each ER receptions or markers like PR or ER, it's very important to do it. So we support this process, annotated process by AI, and of course clinicians check if AI works well in this step, and if they confirm, we can or we retrain again model if it's not good, but we want to do it better and better and better, and at the end we could have the models which work well for and support pathologists to not counting by eyes cells like they do it in this it's very time consuming and not necessary. Machine could do it very well, and only clinician confirm yes this is right or not. And the last one, what is important also to check the different resolutions. So because like in the microscope we have different step in resolution. So we try to the same do what clinicians do by AI, and it's very important for example for tissue detection. So that's why we support also this step by this kind of model. And right now we working on annotate steps, so it's the project is ongoing, and the next phase will be deliver solution which could work on the same like previous projects on the platform, and the models could be ready on the platform for clinicians, for pathologists, for daily jobs. We also on the platform support radiology because sometimes pathologists need to see the radiology data to be more sure about pathology diagnosis, pathology, and to write report. We also support filling the reports because it's other problems. There is no good standardization on this step. Many pathologists, what Maya said, write natural language text in the documents, so it's hard to analyze this kind of data for example for the second opinion. So that's why we cooperate with ICCR Pathology Society, which help to standardize report like CAP in US. They work together, and it's very helpful to filling, just click automatically some reports fastly. And additional what Dr. Barczak shows, there was a gamepad. Gamepad could support in checking or checking the tissue, analyze the tissue, but also there is a microphone, and we want to use this microphone to just filling the report from voice and transcript and standardize by AI to fill ICC report or own templates reports which hospital used or pathology department used. So we want to speed up the process, what today pathologists do, not only by AI, but also filling the reports, because we see that a lot of time it's consuming for the pathologists spend a lot of time for something what is not needed. It could be faster, yeah. There is not we talk each other to here, and we see that in Ireland, in US, maybe it's better, but in East countries or South countries, Africa countries, there is not a lot of pathologists, and we have to support them because it's stuck of cancer diagnosis, other diagnosis today. For example, in Poland, we have to wait 1 month for first diagnosis. In pediatric cancers is sometimes more. So it's a horrible time for others and families, etc. So we started this project because of this, because my son and my brother have a brain cancer, and I saw how the process looks like, and based on my experience from technology, I'm computer scientist. I see that we can help by computer, by software, by AI to speed up your job. We want to support you because we see that together we can do better cancer diagnosis. So thanks for your time, and yeah, we are welcome on our booth at the end of this room. Thank you.
Any questions? Yes.
How many laboratory laboratory to propose your system for helping, I mean, the connecting the different laboratories in your country so that they have access with patients and also the physicians have the connected. Can you have statistics for this? How
Yes.
many laboratories?
Yeah, so thanks for these questions. Yeah, we started this project in 2021 as a full job work, and from this time, from that time, we have today 13 hospitals, 30 departments, mainly pathology departments, because we also want to have a radiology department. But right now we focus on pathology because we see the urgent problem is here. But we saw that many pathologists use only microscope. So for them, it's not good time to use AI or something like this. So for them, that's why we start to do it also manual whole slide imaging software, PathoCam, which support digitalization from microscope, from camera. But for them, it's something where they change microscope habits to digital habits. So that's the big change. COVID changed a lot, but it's ongoing process. So 13 hospital, but mainly from Poland, but we also have installation in Swiss and in South Africa. And maybe Syria, because yesterday we talked about this. One pathologist comes to us about other problems in Syria. So we are here because we want to contact with other pathologists in different countries because it's global problem, not only Polish problem. Or we have talked with Ireland pathology department the same. They thinking about digitalization. So it's right now good time to start educating in this field and cooperate. We are open for any type of cooperation. It could be in education field, because we start like in Poland, we start from education field. We start cooperation with Polish Society of Pathology, and they start using platform during COVID because they want to educate, and it was impossible to meet like right now. So they looking for platform where they can show slides online. Yeah. So this way we start cooperation in Poland, I think it's easier way to go this way because it's not so regulated. Education could be the software for education could be without certification, something like this. But at the end, we are ongoing process also in certification, but it's take time and money. So we need more reference, more customers to do it.
Just a quick comment. All the products, all the trial that you did is on the diseases. From pathologist's point of view, if you want to help us, big majority of our works are GI endoscopic biopsies, and big majority of them are normal biopsies. Has anyone looked at doing AI looking for a normal tissue so we don't have to look? Because when you're diagnosing a cancer, you still need a pathologist to authorize that. And not only that, in my country, you need 2 persons to say that it is cancer, especially on the first diagnosis. So if you want to help us to save more time to look at more important diseases, and AI to look at something that can say it is normal. That's my
Thanks for this.
I think that's a good question because you're not the only people who are looking at breast cancer and prostate cancer. We already have the page application which FDA approved.
AI, yeah.
And you have AI looking at things. You also have IBEX.
Iforia, yeah, IBEX.
Doing the cancers.
Yeah.
So are we reinventing the wheel in Poland? Maybe 5 years behind or whatever, or is this really the most important problem to tackle with AI?
I saw that today the main problem is digitalization, not AI. AI is something what it could be maybe next years. So we saw this, and that's why we at the same time start radiology, because in radiology AI it's right now, because they are ready in digitalization. So today we offer platform for working remotely, telepathology, because that's the main issue right now if we talk about pathology, because they could work remotely. They could go to holiday and check urgent cases from phone or something like this. Not so we saw that AI it's something maybe next, not now. If we talk about the problem, other problems, not only cancers, yes, of course, we hear that it's, for example, for cytology, just check, looking for region of interest. That's all, and show this. So, what you think? Take time to check whole tissue, maybe AI could do, just show the region of interest, nothing else. So we looking for partners to start others tools, models which can help you in daily jobs. So if you are open for cooperation, like R&D cooperation, we also can do it. That's why I'm here, and we are open for any type of cooperation. It's not urgent to do it only cancers also. Yeah. Thank you.
Any other questions? So we're finished a little bit early. We start lunch early. Okay, so on the stairs again. Okay, so we want a group photo of everybody participating today back at the back. And then we'll go down to the stairs, take another photo, and have lunch. But I need to give you your. Decorate your whole wall. Official photos. That's how it was all of the show. Yeah, this is a big one. Yeah. Yeah. Yes, tools. This is just or this is not right. Folded by launches. It's and there's or it's very
sometimes they have this pain. See, right? But to be there. So, like the things so that
clinical studies. So now sharing this afternoon to be taking on for our next workshop during lunch is by Sir Mahmoud Rehan. He is the CEO and presented for 5 minutes, and he is here to deliver a talk on easy detect colon test and its role to facilitate early detection for colorectal cancer.
مش هتعرف. ما اشتغلتش. هاي لك صفحة. Startschan, adesso monita.
Good afternoon, everyone. It's my pleasure to join you today and present BioAmerica and the BioAmerica product. And the EasyDect is considered as the most BioAmerica's product. BioAmerica is a global biomedical company that develops and manufactures diagnostic and therapeutic product, enhancing people by providing them product in convenient and affordable way. First, I want to discuss with you about the incidence rate of colorectal cancer in MENA region. By the way, I am Mahmoud Rahan, the business development of BioAmerica in MENA region, so my work is focusing in our region. Incidence rate of colorectal cancer in MENA region, for example, in Emirates, is considered the second cancer in Emirates is colorectal cancer. It represented 10.6% of cancer cases. So, incidence rate of colorectal cancer increasing year by year, so it's a time to take action. Based on American Cancer Society guideline for colorectal cancer screening, it's recommended annual screening by fecal occult blood test or FET, colonoscopy each 2 years, DNA methylation method every 3 years. About the ordinary method for FOBT, we faces a lot of disadvantage of other FOBT, like handling of stool, rapidity of result, accuracy, a lot of false positive and false negative result, inconvenience, dietary restriction, difficult to process sample meaning. What if a simple test could help detect the early warning sign of colorectal cancer? This our hero today is EasyDect. Before I represent EasyDect, I wanted to make brief demonstration for our product to see how it's easy and convenient this test. This is our product, and this envelope inside our product is just 5 plain paper. Why 5 plain paper? The first paper just tests the water in the toilet, just throw it, because we need to be sure the water is ready to you to perform the test, maybe contain disinfectant, maybe interfere with the result test. So the first paper should be plain, should be negative. After that, we have 3 papers to test your stool 3 times. After each bowel movement, just throw the paper in toilet. If get colored, green or blue, it means positive. If no color, it means negative. The last paper is considered as positive control to prove you that our test is working good. So now about our EasyDect, the main advantage of this test, no handling of stool at all. It's only FOBT overall, no handling of stool, just throw paper in toilet. Handling of stool is considered a barrier for a lot of gastroenterologists to convince their patient to perform the test based on our survey in a lot of countries in this region. So handling of stool is our key point here. Perform the profile of patient home, so the test completely done in the home, and the result will, you will get the result within 2 minutes in your home. So no lab processing at all. Easy to read result, no dietary restriction, is different about other FOBT, which diet restricted, you should fast 3 times, 3 days before you're doing a test, about red meat like that. But in our EasyDect, no diet restrictions at all. Result within 2 minutes, FDA clear. By the way, EasyDect is available in American market through 30 years ago. No sample meaning, no lab required, lowest screening cost, regular testing recommended, suitable for national screening campaign. And I will discuss this later. Accuracy of EasyDect via other FOBT. Of course, the greater number of stored sample provided per patient because you test here 3 stored sample, not only 1 stored sample. The higher the sensitivity for detecting cancer or advancing colorectal neoplasia. Testing fresh stool. This test is working on fresh stool. So it's not like take your sample and return it to lab for analysis. So it take more time. And during this time, hemoglobin maybe degrades because hemoglobin in a stool sample is stored in liquid-based buffer and decrease by 29 nanogram per milli daily. Another comparison between EasyDect and other FOBT to clarify my point here, handling of stool, no, because it's the only test without handling of stool at all. Other tests, yes, stool collecting device because a lot of other FOBT even fit a lot of process required, but with EasyDect, the process is too convenient, it's too affordable, it's too easy to perform. EasyDect is 2-minute at-home test for a determination of fecal occult blood, early warning sign for colorectal disease, including colorectal cancer, no stool handling, and this is, as I clarified before, about the how many people inside. It's 5 people. A lot of clinical trials proceeded for EasyDect in United States hospitals and in Spain and in China. Also, we under processing now a lot of studies in Saudi Arabia, in Emirates, in Egypt as well. So the conclusions for this study is positive percent agreement, 93%, negative percent agreement, 97%. Another study is this 93%, 91%. This in Spain is compared direct against colonoscopy, as is shown here. The sensitivity 72.9%, specificity 99.2%, and negative protective value 92.5%, positive protective value 96.4%. Based on a study in Johns Hopkins, the EasyDect is preferred by ratio 10:1 via other FOBT in Johns Hopkins, based on a study in University of Chicago, 100% accurate at predicting the finding of surveillance colonoscopy. We're speaking here about the comparison between EasyDect and the DNA methylation test and the FIT, as shown here, about the specificity and the sensitivity and the convenience. Here's a point which exactly what I come today to discuss with you about how we want, if we wanted to launch a screening campaign for colorectal cancer in any country, what are looking for what? We are looking for tests to be affordable, the test that encourages the citizen to participate with us. Because based on our survey about in a lot of launching screening campaigns before for colorectal cancer, we noticed the same. If we're using the test complicated and using this test with complicated process for the citizen, no one will participate with you. And we noticed that, for example, in one country in our region, they distribute 100,000 tests for FIT for the citizen. You can imagine how many returned sample to be analyzed by the lab. It's like 15 or 16%. That's what I mean here. By EasyDect, it's simple to create reimbursement code on the system, healthcare system, or the system of the pharmacies, guide the citizen to pick up the test easily from the pharmacies and refer the positive cases to hospital for further diagnosis. It's like that. This is how the thing is done here. If we want to do screening and we wanted to make national screening campaign by EasyDect. I speak like in Egypt, we have like 18 or 19 million people above 45%, 45 age. How we can make this as national screening campaign in Egypt within 5 years or 6 years? Is it take to solve this issue for us? And it depends on the infrastructure on health system, because this test decrease the burden on health system. So it's the best choice if we wanted to proceed launching a screening campaign in the country. Enhancing people health and well-being while massively reducing the total health care cost. Prevention care, early detection is your best protection. Early screening can save life. Early detection saves money as treatment cost rise with later decision, high acceptance due to low cost and in-home result. This is some example of our impression in our region. Some campaigns launched in Egypt and in Dubai, and we got a lot of recommendations from gastroenterologists in Dubai. EasyTech is cost effective and convenient screening test, ideal for large screening campaign. We performed a successful screening campaign with pharmacies in United States in the past. The local organizers were partnered with network TV and the hospital system and engaging with cancer foundation. Screening need to be done regularly. EasyDect meets the demand of time. We all profit economically. So summarize about EasyDect is we can summarize in some few points. I give to you FOBT in your hand. I give to you the test that encourages gastroenterologists to write and prescribe the test with a medication in the prescription, and it is dispensed easily through the pharmacies with the medication, and they perform and privacy at home, and if positive cases, refer the positive cases to gastroenterologists for further diagnosis. So EasyDect, no stool handling, continuous purchase, no dietary restriction, no lab processing. It's convenient and affordable, and encourages the citizen to participate with us if we're launching a screening campaign for colorectal cancer in any country from tomorrow. That's all what I said about EasyDect. Now it's time to take action to launch national screening campaign in our region as soon as possible, because colorectal cancer is rising year by year, and I'm sure it's time to take action against colorectal cancer. Thank you.
Thank you very much, Mr. Bihan. Are there any questions?
So what would be the price for the actual kit, and also do you have any probable discounts for mass, for example, purchases? Thank you.
The price of EasyDect is too cheap. It's like in Emirates, like 90 dirham. You know, you can imagine you test your stool 3 times with 90 dirham.
Is the adult affected by the water in the toilet or by cleaning agent in the toilet could be affected?
Yeah, that's why we test the water first before performing the test by through the first paper. It should be negative, because if positive, it means your water is not ready to perform the test.
Are there any other questions? All right, thank you very much. Mr. Ryan. Good. Okay, so look good. All right, our next speaker is Dr. Naeem Abu Reha. He is a gastroenterologist and here to deliver his talk on indications and findings of colonoscopy
differences and similarities between males and females.
Okay, let's see. Thank you, Sherman. I will give a short introduction regarding gender versus sex in disease in general, then in gastroenterology, and then our study about colonoscopy among females and males. In general, there are differences in different diseases. It could be difference in prevalence, in presentation of diseases, and prognosis. As examples, autoimmune diseases, cardiovascular diseases, and gastrointestinal disease. In the autoimmune diseases, about 80% of the autoimmune diseases common by females. As example, lupus, systemic lupus is the ratio 7:1 for females, and rheumatoid arthritis 3:1. Cardiovascular disease, we know that the incidence is higher among males, the heart attack, and the heart attack is fatal among males. What about gastroenterology? Gastroenterology, there is different diseases were investigated. One of them is colorectal cancer, which is more common among men, and the women is more right colon cancer. Here's our study, previous study, which is investigated the upper indication, the upper endoscopy, gastroscopy for the stomach, the indication and the finding. As you can see in the left side here, esophagitis, inflammation of the esophagus, Barrett esophagus, gastritis, peptic ulcer in general is more common among males. And among females, we found more hiatal hernia and more polyp of stomachs. Here we can see, as example, GERD, gastroesophageal reflex, but comparison between males and females, and we can find again higher rate of hiatal hernia among females, higher rate of esophagitis among males. Why it's different? There is different several reason for that. First of all, genetics. Genetic could impact diseases. Hormonal, the estrogen could be a protective for some diseases, as example, cardiovascular disease. Could be maybe a protective for esophageal cancer and peptic ulcer too. Another aspect is the body structure, the different body structure between females and males. The pear-shaped and apple-shaped could impact the diseases. The different fat storage, the fat metabolism between males and females is different. Another important aspect is the eating habits, which different between males and females. Healthy food, processed food, and another important aspect is the risk factors. Which risk factor? Obesity, which is different in between females and males. In some countries, is higher rate among males, and other country among females. Smoking and alcohol, it's more common among males, which is all of these are risk factors for different disease, including cardiovascular, including cancer disease. So now I will talk about our specific study. In this study, we wanted to know if there are any the differences and similarities between the indication for colonoscopy and findings of the colonoscopy, comparison between males and females. The design of our study was a retrospective study with a collected data. It is a multi-center study, 7 gastrointestinal or GI department, endoscopy department in Israel, in Asuta hospitals. All this patient underwent colonoscopy for different indications. We included all people who underwent the colonoscopy, the first colonoscopy. We included data between the years 2016 to 2022, and we collected the data from the electronic medical records, MD Clone platform, in which platform we have all the electronic data. We included data, demographic data. We included the indication for colonoscopy and the pathological finding and the finding per specific indication too. Here is our result. This is the baseline data. You can see we have about 150,000 colonoscopy females and 136,000 among males. There is no significant difference in the age and in cecal intubation, which means we have a complete colonoscopy. There is a little bit higher rate of better bowel preparation among females. And here we have the indication of the colonoscopy. This is the most common indication of the colonoscopy. You cannot see it. And we can see that abdominal pain, change of bowel habits, constipation, diarrhea, family history of colorectal cancer, and anemia as indication for colonoscopy were more common among females. While FOBT, fecal occult blood test, rectal bleeding, weight loss, polyp follow-up, and screening were more common among males. We will discuss it later. Here we can see the finding. What was the abnormal finding of the colonoscopy? And you can see most of the abnormal finding was more common among males: colorectal cancer, polyp, Crohn's disease, and diverticulosis. Here we can see according to the specific indication. As example, we have here the abdominal pain. We took the people with abdominal pain and compared females with males, the finding. And you can see that the PDR, polyp detection rate, the rate of polyp detected in the colonoscopy was higher among males on all different indications. As example, abdominal pain, it was 66 among males compared to 19 among females. So people with a positive fecal occult blood test, 55% of the males had polyps compared to 41. Again, rectal bleeding and all other indications. Conclusions. We found significant differences between men and women regarding the indication and pathological finding of colonoscopy. This could be helpful for the clinician to make decision and development specific, sex-specific approach. And let us now discuss part of this finding. First of all, the indications: the abdominal pain, change of bowel habits, constipation, diarrhea. Why it's more common as indication for colonoscopy? Maybe because this indication, these symptoms are part of functional disorders. As example, irritable bowel syndrome. So functional GI disorder is more common among females. Here we have a relative updated study from 33 countries. It was included a survey, 73,000 participants, about 50% women and 36% are men. And you can see in the table here that the percentage of people who, according to this survey, who had could have functional disorder, and you can see that is 46% among female and 34% among males. So it's functional GI disorders are more common among females and could be more as indication for colonoscopy. What about rectal bleeding? It's more common in our findings. It was more common among males. Why? Because males have it's related to hemorrhoids. This is the reason for the rectal bleeding. Hemorrhoids, as you can see in this study, it was more common among males. About 60% of the people with hemorrhoids had hemorrhoids. About people of the male had hemorrhoids in this study. Positive FOBT fecal occult blood test, this was unaccepted, that is to be more among males, because in general healthcare seeking and adherence to early detection is more common among males. However, we have this study which, if I think it's from the UK, yes, from the UK. This is screening uptake and positivity rate, people who underwent FOB. And we have the age group, different age group. And you can see that among this study in the UK, the uptake was higher among female. If we look on the total, about 61% compared to 55% among males. We can find the uptake of fecal occult blood testing among females to be higher in all different age group. The positivity rate in general is lower among female. What about the pathological finding? We found that is colorectal cancer more common. I showed you this before, that people, the risk for colorectal cancer is higher among male. The polyp detection rate is higher among male as indication. Why it is so? First of all, we can have here the ADR, the adenoma detection rate. This is a relative very high adenoma detection rate. This means among men, 64% of people who underwent colonoscopy had adenoma, polyp, and women, 50%. It's very, very high, but in this specific study. But we have here 23 minutes withdrawal time. This is one of the measurement, quality measurement in colonoscopy. The what time we reach the cecum and begin to go out, and usually it should be at least 6 months, 6 minutes. But in this specific study, it's 23. It's really too much. So we have other study, and in this study you can see this is the males, and here you can see the females. Maybe this is different. Let's see the total males. We have 50% of the males underwent colonoscopy had adenoma compared to 36%. Here we have again the adenoma, any adenoma among males, females, different age group. In summary, regarding this specific, we found polyp among males more than females in all age group, and could be related to, as example, the nutrition and the risk factor, consumption of red meat as example, which is known as a risk factor. Here we can see the PDR, the polyp detection rate, according to the specific indication. Those who have specific indication, females and males. You can see that among the males, in all indication, the males have higher polyp detection rate compared to the female, the blue one. And you can see in abdominal pain, it's about 20%, and it's higher among people with rectal bleeding, higher among those with screening, and the highest is among people with positive fecal occult blood test, which is very important test as screening for colorectal cancer, as mentioned in the previous lecture. Thank you for their attention, and if there are any question, I will be.
Are there any questions?
Okay, thank you.
Welcome our next keynote speaker, Mr. Jared Bears. He is the COO and representative of Halia, hopefully I pronounced that correctly, Halia Therapeutics of the USA. He is here to deliver a talk on early clinical evaluation of HT6184, a potent selective orally bioavailable allosteric inhibitor of NEX7/NLRP3.
It's going to be perfect. Well, thank you for the invite to come out here and speak today. We're excited about what we have, and I'll give you a brief introduction into our company, as well as our first clinical asset that we've developed internally. To just give you a little background, my name is Jared Beers. I'm a co-founder. I'm Chief Operating Officer of Halia Therapeutics. And at Halia, we are discovering and developing novel therapies to improve patients' lives with inflammatory and neurological diseases and disorders. And so where we really started originally with the company is kind of led us in a different direction. So we started the company 5 years ago with one of our co-founders being a human geneticist and really looking at Alzheimer's disease and the roles of inflammation in neurodegenerative disorders. And what we started to realize that once we got into inflammation and looking at that is that it really reaches across all disease types. At least in the United States, I don't know every region of where everyone's from here, but we have a large problem with obesity, diet, and lack of physical activity. It seems like we all want to work more, eat worse, move less, and we're really starting to pay the price for that. And we're starting to see really a large amount of chronic diseases come into younger and younger populations. And you'll see quite often nowadays a phrase called inflammaging that gets talked about quite often. And that's this whole chronic inflammatory pathway that just seems to be activated in more and more individuals. And, a long time ago, they used to teach us that chronic inflammation was just acute inflammation that had never resolved itself, but we're really starting to understand that that's a very different thing. And so back in about the early 2000s, there was a discovery made in biology around chronic inflammation and this idea of what's really driving it. And this protein structure called the NLRP3 inflammasome was discovered and characterized. And as you can see, the publications since then really, I don't know if my cursor, I guess it doesn't show up, have really started to explode. Today, we're on track to have well over 3,000 peer-reviewed articles released in different journals around inflammation and its role in different diseases. And so we started to really head down this path to understand what was going on. And so this is the NLRP3 inflammasome. This is the core structure. Really just two major proteins or players in this structure. You've got the purple, that is the NLRP3, and then kind of the grayish, blackish is NEX7. And so that's actually what we've gone after, is targeting NEX7 and its function and role in assembly and propagation of inflammation. And so just give you a quick background of kind of the biology and kind of the process that happens here, is that the activation of the NLRP3 inflammasome is really a two-step process. So you've got the priming step that is driven by NF-kappa B and toll-like receptors that form the major structure and the translation transcription of the NLRP3, and then it's transported to the microtubule organizing center where NEX7 resides, and you get the full assembly and the activation in a triggering event of the inflammasome. So right about the time that we were identifying NEX7 as a major player in the inflammasome and its function, other groups across the United States and in multiple academic labs were also recognizing its essential role in this activation. We've been, my brother and I are actually business partners in this company. He's here as well. And we've been in drug discovery for over 20 years. We've seen many drugs go into clinical trials in the United States and a lot of oral small molecule kinase inhibitors. And so when we saw NEX7 was an important player, we recognized that it is a kinase and that it's druggable. And we understood that. The interesting thing about NEX7 is that its kinase function really has nothing to do with its activation of the inflammasome and how it propagates chronic inflammation. It really is its true structural nature that acts as an activator and kind of a scaffolding protein to hold this whole complex together. And so this was really interesting to us because this was something that nobody else had really recognized or discovered yet. So we developed kinase dead mutants of NEX7, and we still saw the inflammasome being activated. We made true kinase inhibitors as well and saw no reduction in IL-1 beta and other IL-18 and caspase-1 production. And so we started to look at its potential to be an allosteric modulator. And so we developed some small molecules that targeted the conformational shape of the NEX7 protein itself, and really went after the idea that we could prevent NEX7, being the yellow protein on the slide, from fitting into that notch, that little space. If we could lock it into a rigid conformation, we could keep it from moving in there and ever causing the self-assembly of the NLRP3 inflammasome itself. And so we started to engineer some cell lines. Sorry, the coloring is a little bit bad on these. You can't quite see them. But what we did here on the one side is we have a fluorescent cell line that expresses under inflammatory state. It will express GFP and show you the activation of the inflammasome. So it was great. We were able to show that with our compound at low concentration, low nanomolar concentrations, we were able to inhibit activation of and the assembly of the NLRP3 inflammasome. The thing that we were asked by David Beers, Dr. Beers, was once the assembly happens, can we actually reverse that with our NEX7 inhibitor? And so our scientists, our team went back to the lab and started to do some more experiments where they activated the inflammasome, got fully assembled inflammasome. We saw SPEC formation. We saw IL-1 beta go up, IL-18 as well. And then we added the inhibitor 7 hours after the inflammation had started. And we actually saw inflammation go away and the structure itself to start to tear apart and disassemble as well. So we had actually created a small molecule that could prevent inflammation and actually reverse inflammation as well. And so this opened the door to a lot of different diseases modeling that we could go after. This is some of the work to show its potency. In the inflammatory space, there's an old Pfizer compound called MCC950 that we use as a tool compound in drug development looking at inflammation. And we were able to develop inhibitors that are 3 times more potent, greater than 3 times more potency than the MCC950. We also have done a lot of single cell proteomic work looking at chemokine and cytokine expression within different immune cell populations. And we are able to add LPS and ATP to cause an inflammatory state, that bottom magenta, kind of purplish cell population. And then up in that clustering at the top is our no treatments, or the pink. And we're able at low concentrations, again, to show that we can revert those cells that have been excited to be inflammatory back to a no treatment state. So we started to look at disease models to get a better understanding of how this drug would work in vivo and not just in vitro situations. And one of the early models we looked at, we've looked at many, many, many different models, but relevant to this conference and what we're talking about today, we started to look at inflammatory bowel disease and some of the models around that in both the acute and chronic setting. We were able to find literature and show in our lab that the NLRP3 complex was vital for the activation of this disease and its severity as well. So we decided to run, first of all, in-house, the DSS induced acute colitis mouse model. What we do is we add DSS to their drinking water. So pretty much give them soapy water, let them drink that for a week. And then we treated them for just a couple days with our drug, and we measured body weight and other histopath scores as well. And so what we saw, which was quite surprising to us, not only did we, sorry, these got out of order a little bit, we were able to suppress IL-1 beta and have a total histopath disease modification score that was favorable, but we also started to actually see repair of the colon architecture after treatment with our compound. So we moved on to a chronic model where we kept DSS in the drinking water and pulsed it for 30 days. Historically, the data is if you continue with this, all the animals will pass away from malnutrition and other disease indications that happen. Weight loss begins to happen quite rapidly in these animals. And you see it about 10 to 15 days, all animals will pass away without intervention and treatment. We tested our compound in this model. We were able to get nearly 100% survival across the board. We were able to see positive cytokine movement. We saw, once again, the histopath was positive. We saw less infiltrating immune cells into the different. We saw the cryptic architecture remain. We saw TNF alpha levels go down, as well as IL-1 beta, IL-6. And so this has led us into this area and really has given us the opportunity that we can move forward in the irritable bowel space. Right now, we're evaluating globally clinical sites and feasibility in different regions around the world. We've completed a phase 1 clinical trial in the United States for normal healthy volunteers, and I'll show you some of that data there. But this is something we put together, one of our researchers, looking at what diseases are talked about the most with inflammatory disorders and what people are most interested in. And as you can see, cancer, of course, gets a lot of funding. It's a big one. It's on there. Obesity, diabetes, arthritis, irritable bowel, gout, Alzheimer's are all diseases that are highly inflammatory and spoken of in the literature quite often. And so this has really opened a huge area for us as a company to be able to go into a lot of different disease indications. And to move this compound forward. So, like I said, we finished our phase 1 trial design of normal healthy. We had 2 cohorts of a SAD, a single ascending dose, and a multiple ascending dose at 4 different dose levels. We dosed very low, just 1, 2, 3, and 4 milligram flat dose across the cohorts. And we found that our drug performed very well. No serious adverse events, and we got very favorable PK and exposure over quite a long time. And we were also able to ex vivo measure some of these cytokines and look at the way we were able to modulate IL-1 beta, IL-18, TNF alpha, as well as C-reactive proteins as well. The interesting thing that we found in doing this study and looking at its pharmacokinetics was that none of this had been able to be modeled in the animals. We had good bioavailability in all of our animal models that we looked at, but in the human, after 1 single dose, we actually saw exposures up to 72 hours or greater. So our drug really stays around for a long time in the system. So we can continue this low dosing and get a very efficacious level in the system over time. And so this was something that was very surprising to us. It opens the doors for a lot of potential and opportunities for different dosing schedules. We're talking about once weekly potential dosing with this as well. And also, because of the idea that we can actually reverse and reset chronic inflammation, it gives us a potential in some diseases that we could move to dosing that just when a flare-up is starting, we can dose, resolve that inflammation, and then the patients can back off of the drug and not continually and chronically take this compound, thus reducing a lot of potential, side effects that could come over, years and years of potentially taking any medication that we see. So. This is some of the PD data that we pulled out of our normal healthy volunteer study. This was a study that we did ex vivo. So the blue is the baseline. So before any of the volunteers had taken the drug, we drew and looked at cytokine levels of inflammation. This is just a small subset that we looked at, IL-1 beta, 18-6, and TNF alpha, and you can see very low levels, which would be expected. These are, normally healthy individuals, of a decent age, so 18 to 60 was kind of the span. I think our median age was around 37 that we had on the study. But then what we did with their blood is that we added ATP and LPS to trigger inflammation, to trick their blood into thinking that there was something wrong. And we saw these spikes in the red of inflammatory markers. So then we had the volunteers take the drug, and 24 hours post-administration, we drew blood again and looked put them through the same conditions that we had in the red bars, and we were able to see that we were able to take everything back down to the baseline expression levels. So the interesting thing around this is that some of the antibodies that we've looked at and that we've seen, especially IL-1 beta antibodies, wipe out all IL-1 beta in the entire body. They just go after it wherever it is, and this can be argued that it's a negative thing. We need some in our system to be able to mount an immune response to a bacterial viral infection. And so the thing that we feel that we have favorable conditions over is that we just take things back down to normal. We don't soak up all IL-1 beta everywhere in the system. We just take down the chronic, the NLRP3 producing, and take it back to baseline to resolve chronic. So that's a real positive that we've been able to see with our compound over other compounds and competitors in the space. We also looked at that same panel of pro-inflammatory and anti-inflammatory markers, and we were able to induce anti-inflammatory cytokines and at the 14-day mark, and we saw the anti-inflammatory go up and pro-inflammatory go down, which was quite impressive for us. To be able to see a real PD marker in our normal healthy volunteer trial. And then, as I talked about, there's a lot of different directions and possibilities for this compound. We've actually developed a lot of different, all targeting the NEX7 protein, but with special chemical abilities to it for inflammatory disorders of the eye. So we've created a topical eye-restricted version of the drug that we could treat inflammatory disorders of the eye. We have a gut-restricted. So if it ever does come up that we start to see systemic toxicities, we can actually target this compound to the gut specifically and just go after colitis and different inflammatory gut ailments. We've got brain targeting versions of the compound that can go directly to the brain for Alzheimer's disease. As well as topical for the skin, and also injectables for joint and spine disorders as well as we've got add-on programs in the Alzheimer's and Parkinson's space as well. So thank you very much.
Thank you very much, Mr. Hughes. Are there any questions?
Have you noticed any adverse effects with the drugs that you guys have given?
So far, we haven't. I mean, we're early in the process. We've just started a phase 2 clinical trial, actually in a cancer indication, a hematological malignancy disease called low-risk MDS. So that just launched in India. Actually, we've dosed our first patient. We've got 30 additional patients in screening right now. So that data will start rolling in pretty quickly. It's much more chronic dosing schedules. So we'll start to be able to evaluate those here in the next few months. We'll get our first readouts. We've got MDS trials starting in the United States as well in the first quarter. We've got rheumatoid arthritis that will be starting up shortly as well, probably within the first quarter as well, which will give us a lot more indications. And then like I said, we're doing feasibility right now for irritable bowel disease, trying to find what regions and across the world that we can open up and recruit patient populations quickly. The United States is a bit saturated in the irritable bowel space, so it's difficult to run trials right now there in that space. You're getting the worst of the worst patients. And that's always to throw a new drug, at the worst patients possible is always, a hurdle that we try not to take. And so we've in drug discovery nowadays, we're very global. And so we need to think outside the United States and start to see a more diverse population and go into those populations sooner and sooner. Thus, the reason we've started in India and then we're here in the Middle East. We're actually opening offices here in Dubai. We've been busy this week here getting all the legal work done for that. And so we'll have a presence here in the Middle East. We've got European presence, United States and India. We've got an entity in Australia as well. So we're hoping in this next year in 2024, we'll have a lot of data coming in. We'll really understand the safety profile of these drugs. Yeah. Yeah. No, I mean, if things go really, really well, 5 years would be awesome. But drug discovery is slow. Unfortunately, it's really slow. And so right now we count on clinical trials and trying to open, like I said, in diverse global markets to try to get as many people on the compound and get efficacy readings, as quick as possible. We're always open to collaborations, and try to move this forward as fast as possible, but safe at the same time. So, yeah, ideally 3 to 5 years would be awesome. But it's a difficult process. I mean, you never know what's going to pop up that slows you down potentially, or you've got to pivot a little bit of your dosing scheme, or really hone in what dose is the most efficacious. And so, unfortunately, it takes time, and it's a hard one to nail down. So, yeah. Thank you.
Thank you. I actually do also have one more question. Do you anticipate or have you noticed any drug interactions with, especially with other anti-inflammatory medications such as NSAIDs or TMIs in patients with inflammatory disorders?
Again, we're early, and the short answer is no, we haven't. The longer, more complicated answer is we haven't fully looked at that. I mean, those are in phase 2 trial, phase 3 trials. We start to really hone in on that and look at drug-drug interaction. The mechanism of action is very unique. And there isn't a whole lot of crosstalk between NSAIDs and steroids, and how they both function are very unique. And so the potential in vitro isn't there, but once you get into the human body, it's a different story. And so can't really speak to it as of right now, but we're hoping no, and the early data suggests no, there shouldn't be. Yeah.
Fair enough. Thank you.
Yeah.
Are there any other questions? Right. Our next speaker will be Dr. Abdullah Zandi from the UAE. He is a specialist bariatric surgeon here to give a talk about gallstone and bariatric surgery.
Hello and good afternoon, everyone. I hope not be tired after the 2-day conference. My topic may be different with other colleagues that talking before I here today. This is very clinically because if you look in this topic of this terminology of this Congress is a lot of pathology, gastroenterology, and all of the colleagues from the clinic and all the lab and also everyone has here. That this one is completely clinically, and it's very, I try to discuss about this one very simply for everyone that understand what happened after the bariatric surgery and before the bariatric surgery. As you know, at the moment in all of the world, around more than 500,000 people every year in all of the globe has bariatric surgery, from the sleeve gastric band, bypass, sleeve plus operations, and also duodenal switch and everything. For this reason, I try to completely explain what we should tell to anybody that have a gallstone before bariatric, gallstone after bariatric, and how we can treat the patient, the risk of the gallstone coming down. Now, gallstone before bariatric surgery. In the past, we have a lot of thing about the silent gallstone. To be honest, at the moment, we don't think about the silent gallstone. The silent gallstone was the time that we don't have any ultrasound, any diagnostic way for the easily diagnosis of the gallstone. But at the moment, a lot of people with any discomfort in the abdomen go to ultrasound and easily they diagnose the gallstone. And this gallstone is not silent. If it's silent, anybody don't go to ultrasound, to doctor, to clinic for this one. But if I send the in a routine checkup and everything, find the gallstone, what happened? If I find the gallstone is a small gallstone, less than 5 millimeters, or big gallstone more than 1 centimeter, less than 5 millimeters is not emergency, but we have looking for about the emergency operations. For this reason, all the patients that go to bariatric surgery, before the bariatric surgery, we have do ultrasound about the liver, about the fatty liver and the cirrhosis and everything, and the NASH and NAFLD and everything about this one. If they have a gallstone, we have tried to do operation in concomitant at the time of the operation, or maybe if has some problem before the operations. The bariatric surgery is two types. One restrictive, like gastric band, like sleeve gastrectomy. What's the difference for the clinic? If you do the restrictive, it's meaning we have direction to the biliary tree, and we can, if have any stone in a CBD or maybe bile duct or everywhere, we can do ERCP, and we treat it with ERCP. But in a malabsorptive group, like a gastric bypass, like a duodenal switch, unfortunately, we don't have any access to this pathway. It is very difficult for treating. If you miss some stone in the CBD after the bypass and the duodenal switch, we have a lot of problem for us and also for the patient, with risk of the pancreatitis and mortality and morbidity, too much morbidity. For this reason, all patients about the gastric bypass group, we have should completely be aware about that has any stone in a biliary tree or no. For this reason, if you have any enzyme disturbance, anything, something like this, any diameter of the CBD be more than 4 millimeters, we have to go to MRCP or maybe endosonography or everything before the operations. And also in a other way, some operations like duodenal switch that is very malabsorptive. If we have go to these operations, we have do prophylaxis cholecystectomy in time of the operation. For this reason, we have ensure about the CBD and this one. I show you this one. Maybe some of our listener here don't know. This is a gastric band, sleeve gastrectomy. In this group, we can easily access to the CBD and with time of the after the operation and any time. But in a gastric bypass, duodenal switch, and pancreatic biliopancreatic diversion, we don't have any access to the CBD after this one. This group is the new one. We told this sleeve plus. In the sleeve plus, fortunately, we have to access to the CBD at this group also. And in the other hand, we have the two completely different. After the bypass groups and malabsorptive group, the bile salt in our intestine completely changed, and the risk of the gallstone is more than the restrictive like the gastric band and sleeve gastrectomy. For this reason, if you can see here, after the gastric band, as after the sleeve gastrectomy and after the gastric bypass, is completely different rate of the gallstone. For this reason, if you have any restrictive, any malabsorptive operations, we have to prevention of the gallstone. For this prevention, we have 2 or 3 medication for this one. One is urodeoxycholic acid, and another one is probiotic. These 2 groups, if you prescribe for the patient after the bariatric surgery for the 3 to 6 months, the risk of the gallstone and gallstone complication and operation is completely coming down statically. For asymptomatic, I told you before, asymptomatic gallstone, at the time of operation, we have to surgery and remove the gallbladder, because anything happened after the operation, for example, after the all operation, the risk of the complication of gallstone is going high, especially for the cardiac surgery. All patients at the time of cardiac surgery, before we have done any ultrasound about the gallbladder, because after the cardiac surgery, if something happened, cholecystitis, pancreatitis, the risk of mortality is more than 50%. For this reason, for these patients, and after the bariatric, for the first day, 2 days, third day after the operation, we have the cholecystitis or maybe pancreatitis. If you want to go to for the any endosonography, ERCP, something like this, where the risk of the complication and risk of the leakage and risk of the bleeding is going high. For this reason, all asymptomatic gallstone, at the time of the operation, we have removed gallbladder before this one. For the prevention, I told you, and the control, we use urodeoxycholic acid and also probiotic. And also this one is show you a study about the 4,800 people put the 500 to 600 milligram urodeoxycholic after the operation for the 3 months. They coming down the risk of the gallbladder stone. And another randomized trial you can see here, they show about the coming down with the probiotic and also urodeoxycholic both together. But for this reason, we have these 2 ways. After all of the bariatric surgery must be prescribed for the patient for the 3 to 6 months for prevention of the stone and also prevention of the complication of the stones. All these documents show you the efficacy of this treatment. And the dosage of this 500 to 600 milligram urodeoxycholic acid and probiotic every day 2 times. If after the post-bariatric surgery, we see in an ultrasound or some pain and everything, what we can do. All patients after the bariatric surgery, if you find the gallstone, as soon as possible, we have to go to operations room before any complications. And also, unfortunately, if you have the gallbladder stone and also CBD stone at the same time after the bariatric surgery in the group of the malabsorptive, like gastric bypass, like duodenal switch, like biliopancreatic diversion, we have a really big operations. We have to, at the moment, fortunately, we have to long ERCP core for this long, but unfortunately, we don't have a lot of gastroenterologists can do this one, because we have to at least 2 meters go to inside and the retroward go to for doing ERCP. Another way is at the time of the we can go to lap chole, laparoscopic cholecystectomy. At this time, we open the distal of the stomach, and our gastroenterologists come with from one of the ports, 15mm port, go inside the stomach, remnant of the stomach, and come to CBD and remove the stone from the CBD. If you can't do this one, unfortunately, we have to open the CBD, and opening the CBD, 5mm, 6mm CBD is not very easy for the surgery. It's very hard surgery, and I'm sure at least in all of the world, maybe you can find more than 100 surgeons that can do laparoscopically this operation. We have to go to big operation. But this is much better. We all our survey and study before the operation, And if you find that any patient with gallstone after the bariatric surgery, as soon as possible, go to operation. And on that one is all documents about this one, and this is nice for you. Thank you very much. If you have any questions, I will.
Thank you very much, Dr. Gandhi. Are there any questions? Thank you. All right, we will have a slight change in our program. One of our post presenters that was scheduled for yesterday, Dr. Priya Devadas from the UK at Guy's Hospital, will be presenting her talk on pregnancy-associated breast cancer.
I can see the present.
This is your presentation. Let's close this one. And let's see, this is yours.
Priya, my name is
Priya, it's questions from today or from yesterday.
Yes, it is.
Let's see. Okay. Let me see your name. Maybe the search. It's from yesterday.
Yeah, I can do date one. Yeah. Date one.
And that one?
Yeah, this is for day.
This is. Well, we try to find it.
Yeah.
Maybe
Yeah,
I mean, this is this one.
Good afternoon, everyone. Thank you for giving me this opportunity to present my poster here. So my poster is titled Pregnancy-Associated Breast Cancer. Pregnancy-associated breast cancer is diagnosed during the first postpartum year or during pregnancy. And this is the second most common malignancy affecting pregnancy and affects around 1 in 3,000 women. The average age of women with pregnancy-associated breast cancer is 32 to 38, and only 6.5% of all cases of breast cancer affect women aged less than 40 years. So actually, as we see, the burden is quite high. And this is very important because we have to look all aspects, including the mother and child. And it's confounded by multiple variables, and we have only few studies which can modulate or define the treatment of this particular issue. So I'm going to share with you my experience with one of the patients which we saw in our hospital. And she presented actually with 3 months history of presenting with a right breast lump and at the 13th week of pregnancy. So she has previously had 3 children. And regarding the family history, her paternal aunt had breast cancer as 40, and her paternal grandmother at the age of 70, and quite few other relatives with breast cancer as well, and ovarian cancer.
So on clinical examination, we could just feel a lump of around 30 millimeters in the lower outer quadrant, clinically felt malignant with some skin indentation, but the axilla was free. And we had to go on with her biometric measurements to define the further treatment, including her BMI, which was 37. And the estimated date of delivery was in October last year. So with the initial assessment, we further proceeded with further investigations, the baseline investigations, one of the important modalities of the triple assessment of breast cancer. An ultrasound scan was done. We couldn't do a mammogram because she was pregnant at the moment. So ultrasound scan showed a lump of around 29 millimeter. It was classified as U5 according to the Bired's criteria, which means it sounded malignant. And we had a fetal scan done at 20 weeks, and that was normal. And the core biopsy results guided us towards it being a grade 3 ductal cancer, which was ER positive and HER2 negative of size 28 millimeter. So we had the initial plan of surgery as she was 13 weeks pregnant and she had crossed the first trimester. So we went ahead with surgery and we did a mastectomy and a sentinel lymph node biopsy on the site of cancer. We proceeded with a mastectomy in a view to avoid radiotherapy as she was pregnant, because breast conservation is always associated with adjuvant radiotherapy. So we decided to go ahead with mastectomy. And the biopsy results showed 2 out of 3 nodes were positive on the sentinel lymph node biopsy, and all the margins were clear. And at the 20 weeks of pregnancy, she had an oncology review, and we started her on adjuvant chemotherapy, being the 2nd to 3rd trimester. And she was started with FECT chemotherapy for 5 cycles, and that was stopped. And she had an elective delivery by LSCS in the same year, in the month of September. And then since we had lymph nodes positive on the sentinel lymph node biopsy, we went ahead and did axillary node clearance following her delivery, which showed around 15 of the lymph nodes, like total of 6 out of 14 lymph nodes were positive. And then the chemotherapy was continued. She had adjuvant chemotherapy with abemaciclib, and then she had Zometa. And then after her delivery, since the lymph nodes were positive, she had radiotherapy to chest wall, SEF and IMC of around 50 grays and 15 fractions. And then she was started on tamoxifen. So she had her genetic testing done in view of her family history, and hence the Manchester score was 14. We didn't go for further testing. And we had a CT staging done because of the nodal positivity, and that was negative. So the whole treatment was continued according to the guidelines. And this is what the guidelines says when a pregnant patient with breast cancer is seen. So in the first trimester, we usually discuss either termination, though it is non-therapeutic, or either continue pregnancy. So with our patient, we continued the pregnancy. We went ahead with primary surgery and then followed her with chemotherapy and radiotherapy, and also the adjuvant endocrine treatment. If it's in the 2nd or the early 3rd trimester, we usually advise surgery, or we can even go with a neoadjuvant chemotherapy in case if the tumor requires neoadjuvant chemotherapy. It depends upon the hormone profile of the tumor, the size, and then decision about any adjuvant radiotherapy later if BCS is contemplated. And then followed by chemotherapy and radiotherapy and endocrine therapy as in the first trimester. And if it's the late trimester, then surgery would be the late 3rd trimester. Surgery would be the first choice, followed by the regular chemotherapy and adjuvant treatment. So this is the summary of my patient. So she was a 36-year-old lady who presented with breast cancer at 13 weeks of pregnancy. And according to the hormone profile of the tumor, she was initially treated with surgery and then later on with the adjuvant modality of treatment. Thank you very much.
Thank you for the presentation. Is there any question? Yeah.
Yeah, so usually that's what I said. If it is in the first trimester and we are contemplating for chemotherapy according to the tumor burden and how she presents, like in case if she had positive axilla, in that case, then we have to start her on chemotherapy. Then we discuss termination of pregnancy because definitely that's going to be adverse to the child. So if it's chemotherapy is contemplated in the first trimester, then probably termination of pregnancy needs to be discussed with the patient. But I think during the second and third trimester, definitely it's safe to give chemotherapy. The child was followed up after the delivery and the child is doing fine. So did not have any adverse effects in that case. One more thing, what is challenging in these patients is like we had to discuss fertility preservation, like ovum preservation, and then we had to discuss it with the gynecologist. So in case if she needs further children in the future, because chemotherapy can cause like premature menopause. So we try to give the options of the fertility preservation with the gynecologist was discussed and everything was taken forward. So the child is doing fine.
Yes, thank you. Our next presentation is from Dr. Rima Varek about salutogenic approach to managing irritable bowel syndrome, exploring the efficacy of the food map diet to revive IBS patient quality of life. It's not here. Okay, we will go to the next speaker, Dr. Liliana Saikaro. Okay. Histochemical and immunohistochemical study of abnormal collagen in scleroderma and lichen sclerosis.
Hello, everybody. My name is Liliana Sheikaru. I come from Romania, and I'm very happy to share with you our results of our studies in scleroderma, localized scleroderma, so-called morphea, and lichen sclerosus. So our aim was, our aim was to study collagen type 1, 3, and 5 distribution in morphea and lichen sclerosus from the point of view of what we can observe in conventional and special stains in optical and polarized microscopy and demonstrate with that what we found with the aid of immunohistochemistry. Why did we decided to study this diseases is because in histopathology sometimes it's very hard to distinguish between one and that, and so we consider that our study would have a sense. Let's talk not too much about collagens. We all know how important are them in extracellular matrix, and especially collagen 1, that means about 19%. And but not forget about collagen 3 and collagen 5 that are also very important. All are fibrillar collagens that are important to form collagen fibers. As our studies before our research, before starting our research in about collagen in scleroderma and lichen sclerosus, we found that in scleroderma we must find an increase in fibrils of collagen type 3. We must find type 1 procollagen distinctly increased in the lower dermis and subcutaneous tissue. We must find deposits of collagen type 5 around vessels and appendages, and we must find decreased collagen 5A1 in papillary dermis. In lichen sclerosus, we knew we must find increased expression of all types of collagen 1, 3, and 5 in all dermis, and an inverse proportion of elastin fibers and collagen type 5 in areas of collagen remodeling with hyalinization. From a historical point of view, we were amazed of some studies that lasted almost 2 decades about picrosirius thread stain and polarized microscopy in study of collagen. And about 2 decades, everybody knew that collagen fiber type 1 are red-orange in polarized microscopy of picrosirius thread, and yellow-green in and yellow-green, the other, the thin and the thicker fibers. But in 2021, one study that reviewed polarized microscopy with picrosirius thread assessed that picrosirius red stain is suitable for qualitative and quantitative assessment of total collagen, but is not able to distinguish between collagen types, and we should use immunohistochemistry studies. So our study was concentrated on 30 cases of scleroderma and 30 cases of lichen sclerosus. We used histochemical studies with hematoxylin eosin, vancomycin for elastic tissue, and picrosirius thread, and immunohistochemical studies with collagen 1, A2, collagen 3, A1, and collagen 5. In about picrosirius thread stain, we used a kit from UPCAM 150681. We use a manufacturer-provided protocol that is very simple and does not last too much, at about 1 hour. We noted what providers said we should obtain, that is, in light macroscopy, collagen fiber must be red and muscle and cytoplasm yellow. And in polarized microscopy, type 1 collagen or thick fibers must be yellow-orange birefringence, and type 2 fibers thin must have green birefringence. But we also noticed that the manufacturer said that it's unclear if the birefringence in appearance of the fibers is due to orientation, thickness, and packing of the fibers rather than reflecting different types of collagen fibers. So in scleroderma cases, we notice homogeneous fibrosis in entire dermis. We notice that elastic tissue was preserved. In picrosirius red stain, the same red homogeneous expression, and the variable birefringence from spectrum of orange-red to yellow-green. These were some prototype images. The first one is hematoxylin eosin. The second is picrosirius red in light microscopy. We see that homogeneous red expression. And the third image is in polarized microscopy, where we can see a mixture of especially orange spectrum and yellow and red. Our 30 cases of Morphea were analyzed. We used Excel soft to make our analysis, and we found a greater spectrum of orange-red at about 2/3, and a smaller spectrum of green-yellow. In lichen sclerosus cases, we noticed dermal fibrosis. a loss on reduced elastic tissue in papillary dermis, an intense red expression of abnormal collagen of picrocerius red, and the birefringence predominant orange red in polarized microscopy with picrocerius red. Now in our stains, we've seen the same red homogeneous expression in picrocerius red light microscopy, and the more red-orange expression in polarized light. And the studies, all that 30 cases showed us the same 2% predominance of orange-red birefringence. Then we decided to apply immunohistochemical method, how our study of research said us. And we followed mixed protocol. We used our daily protocol of provided by DACO Agilent, on which we used a protein block that was absolutely necessary for our reaction to be good, to be assessed. And about the antibodies, we used 2 types of antibodies from Santa Cruz and Protein Tech. All antibodies were very good, but they were concentrated antibodies for research only. So we have to experience and to establish our protocol and our dilutions. We must say that for collagen 1 to be expressed, the reaction to be good, we need to make enzymatic digestion with protein kappa. And here are prototypes of images. In scleroderma, we obtain a very intense expression transdermal of collagen 1, but that 2 methods of epitope retrieval, heat-induced and enzymatic digestion, were very aggressive for dermal collagen, and that was the picture that demonstrated. But in comparatively, in lichen sclerosus, dermal collagen was not sensitive to this treatment, and the dermal collagen looks better in our images. And the same collagen 1 was positive in entire dermis. About collagen 3, we notice the same intense reaction in scleroderma and in all the dermis. And in lichen sclerosus, an attenuation of the expression in lower dermis. We also made some immunofluorescence with collagen 3, and we noticed an intense expression in scleroderma and an attenuated expression of lichen sclerosus. About collagen 5, we do not find too many things in literature about its expression in normal skin. We noticed that in scleroderma, we had only a slight expression in papillary dermis at dermoepidermal junction, and more consistent expression in lichen sclerosus. And this was in accord with some studies that we read that in lichen sclerosus, collagen 5 is an important factor of pathogeny of lichen sclerosus. So in conclusion, we must note a more intense orange-red birefringence in lichen sclerosus than in scleroderma, and maybe this is due to collagen type 5 deposits. The intensity of expression of collagen 1 and 3 were similar in scleroderma and lichen sclerosus, and the difference in between being done maybe by collagen type 5 deposits. The type of collagen in scleroderma was more sensitive to aggressivity of our methods of epitope retrieval, and its reaction was similar with normal skin. Collagen type 1 needs aggressive retrieval, supporting that collagen 1 is covered by collagen type 3 terminals. Collagen type 5 was more expressed in lichen sclerosus than in scleroderma. And picrocerius red stain alone cannot differentiate between types of collagen fibers, but this stain in light microscopy and polarized microscopy has its utility comparatively with other collagen stains for enhancing and even detection of collagen expression when other stains fail. And thank you for listening.
Any question? Okay, thank you, Dr. Diana. Now we have two short poster presentation. The first one is about relationship between focus on different level of BMI women of reproductive age of UAE from Mr. Maram Yagi, Mr. Marwa Nasir, Mr. Ilyas, Ilyas Muhammad Ahmad, Mr. Mona, Ms. Mona, Abdurrahman Osman. Yes.
Thank you very much for having us today. My name is Marwa. This is Maram, Ilyas, Mona, and Hamshari, and we're going to be discussing the relationship between polycystic ovarian syndrome and different levels of BMI in women of reproductive age in the UAE. And we're from Gulf Medical University in Ajman.
So, hi, my name is Ilyas Ahmed. And to begin our presentation or poster, I just want to give a little bit of a just background of what PCOS is. It is called polycystic ovarian syndrome, and this actually is one of the most common hormonal disorders seen in females, almost 5 to 10% of reproductive age. Now, PCOS has almost like 3 criteria. You have menstrual issues or fertility issues. You have high androgen levels, which causes facial hair growth or like male hair growth, male pattern baldness, things like that. And you also have ovarian cysts. And that basically is what we see in PCOS. Now, my part here was the background, and basically it's almost like, why did we choose to do this study? And we chose to do it because we really wanted to understand the relationship between body mass index levels and the occurrence of PCOS in women residing in UAE, because we believe that it's crucial in developing targeted prevention and treatment strategies. Because if you are not aware, PCOS is its treatment is all over the place. You have supportive care, you have people taking SERMs, you have people taking all these type of drugs. So we feel like that we can help in that treatment. It can be a lot better for these people. So if I can now call on my co-authors for now the objectives.
Okay, so our objective for this study was to explore the relationship between PCOS and the different levels of BMI in women of reproductive age residing in the UAE. So we collected patients' data from Thumbay University Hospital, and we collected the hormone levels that we're going to talk about shortly in a bit, but mainly testosterone because it's the main hormone that varies between the different BMI categories, which are the overweight, obese, and normal weight. And we're going to be talking about all of these right now, but first we got to talk about our methodology for this research.
So for our methods, we collected data on menstrual disorders, anthropometric measurements, and hormonal levels from 56 PCOS patients based on the Rotterdam criteria and 55 non-PCOS patients. We used medical reports from the Thumbay University Hospital and UAE Ajman. Therefore, our study is a retrospective cross-sectional study. And for data analysis, we used the SPSS software, Microsoft Excel, and MedCalc with a significance level of P less than 0.05.
Okay, so I'm going to be talking about the results, and with the results, it's important to speak about the pathophysiology of PCOS. So you know that it's caused by cysts in the ovaries, and this happens due to, since our topic is about BMI, so we know that insulin levels are going to be high in this, and this causes steatogenesis, which will cause an increase in androgens. And when androgens are increased, this causes gonadotropin hormones to have a negative feedback on the female hormones, which is there's an increase in LH and there's going to be a decrease in FSH. And this is very important in our results because as we can see, we saw that there are significant p-values when we did a ANOVA, which is because we took all different categories of the BMI, and there was a significance in testosterone, estradiol, and prolactin, which shows that these, if we, for the future, when we talk about treatment, as Elias has spoken before, these are really important if we test them to know what is their next step in their doing, and for them to also take care of their BMI, their body weight levels, so that they can prevent PCOS. And it's also really important when it comes to checking their hormone levels when it comes to the patients between different BMIs. We saw that people who are obese or people who are overweight, it increases more than the BMI has increased. And this is also shown in our results.
Okay, and we can see right there that there's a table talking about the correlation between BMI categories and the hormonal levels, including testosterone, estradiol, prolactin, FSH, LH, and TSH. So we obtained the correlation coefficient and the p-value to determine whether the correlation is significant or not. And we saw that testosterone had a significant positive correlation with increasing BMI. And that explains the hyperandrogenism we see in PCOS. We also saw that estradiol had a significant negative correlation with BMI, meaning that those with a normal weight had more estradiol levels in comparison with those that were overweight or obese. And prolactin and LH both had a significant positive correlation with BMI, whereas in our study, FSH and TSH did not show a significant correlation, although it was positive. And now the conclusion part.
Okay, so the current study classified participants into 3 groups based off of BMI, as Mona has said, normal BMI, overweight, and obese. And we did that in order to see the relationship between BMI and PCOS. And so we wanted to see, does a higher BMI induce this syndrome? How exactly does that happen? And at which BMI category or value is PCOS consistently and reliably diagnosed? So the discussion of hormonal fluctuations is crucial to understanding all of this, as it tells us the way in which BMI relates to PCOS, which is a hormonal disorder. So to begin, one hormonal change that there is that as there's an increase in BMI, there's a decrease in estrogen. And this inverse relationship may be due to and attributed to the fact that the conversion of androgens to estradiol in adipose tissue is less efficient in obese individuals. And so this causes an even greater increase in testosterone, which I'll get to shortly. Additionally, there's a positive correlation between a high TSH and FSH levels in PCOS. So the former, FSH and TSH, as they increase, there's an increased likelihood of PCOS diagnosis as well. But although this is true, the correlation is not significant as depicted by the p-value greater than 0.05 with a 95% confidence interval. Furthermore, an increase in androgens, which are the hormones testosterone and prolactin, in addition to the effect of obesity, as I've just described, yields a decrease in estrogen and progesterone. Moreover, this increase in androgens also yields an increase in LH, which is luteinizing hormone. And this hormone triggers the further production of testosterone. And so with that, we can see a positive feedback mechanism because as luteinizing hormone increases, testosterone increases. And then as testosterone increases, luteinizing hormone also further increases and amplifies the production of LH. Thank you.
So coming basically to our conclusion, what we really want you to get from our study is that one of the things is that we want physicians to use BMI and obesity as a predictive value or predictive risk factor for the development of PCOS. And at the bottom of our study, we also wanted to demonstrate that a substantive correlation between BMI and hormonal fluctuations in female subjects with PCOS in the UAE and distinct BMI categories markedly influence hormonal profiles in PCOS patients across a range of age brackets. Now, again, these findings are crucial in finding treatments and options that are more tailored to individuals with PCOS. And thank you so much for your attention. Thank you so much for listening.
Thank you for your presentation. We have time for short question. No question? Okay, thank you. We will move to the next presentation, next poster presentation about. The next presentation about the relationship between the thyroid stimulating hormone TSH level and the occurrence of endometriosis among women residing in the UAE by Muhammad Barakat, Ayham Khan Ansari, Yaman Maher, and Sarah Kamil.
So hello, good afternoon, everyone. I'm Mohammed Barakat. We have Yamin Maher, Ayham Ansari, and also Sarah Kamil, who couldn't make it today. We're third year medical student studying at Gulf Medical University here in Ajman, and we'd like to present to you guys our research with the title of Relationship between the thyroid stimulating hormone level and occurrence of endometriosis among women residing here in the UAE. Our research took place in some university hospital in Ajman under the supervision of Dr. Sovan and Dr. Palab from the Department of Biomedical Sciences in the College of Medicine. So we'll start with an introduction about endometriosis. What is endometriosis? Just in simple words, endometriosis as a prevalent gynecological disorder affecting reproductive health of women, and characterized by the growth of endometrial tissue outside the uterus, which causes pain and infertility. Some research studies suggest a link between endometriosis and thyroid stimulating hormone levels. So we wanted to explore this relationship among the women residing in the UAE with the aim of unraveling the variation of TSH levels and the occurrence of endometriosis. Our main objective was to determine the relationship between the levels of TSH and the occurrence of endometriosis here in the UAE.
Okay, so our methods included 22 endometriosis patients and 18 non-endometriosis women. The study collected data on menstrual disorders, anthropometric measurements, and hormonal levels from the medical records of Tomba University Hospital in Ajman. The data analysis was performed using SPSS, Microsoft Excel, and MedCalc with a significant level set at p-value less than 0.05. Now for our results and discussion. From the first table, our study, 1 minute. Our study found that the majority of endometriosis patients, which is around 63.6% of endometriosis, were aged between 25 and 39 years, and around the same percentage were married. The average height, weight, and BMI of endometriosis patients were 159.5, 69.5, and 27.3 respectively. The study did not find any significant correlation between BMI and the levels of the various hormones like testosterone, estradiol, prolactin, total T3 and T4, TSH, FSH, and LH. Now, the second table, it compares the levels of TSH between endometriosis and non-endometriosis patients, and it shows significant difference in the levels of TSH with in women with and without endometriosis. Then the next table shows different hormonal levels among endometriosis and non-endometriosis patients. From the table, testosterone shows a higher than normal value in patients with endometriosis. Estradiol and prolactin and TSH show lower than normal value. Total T3 and T4 are lower than normal, but not significant, and LH shows higher than normal, but also not significant. The next table correlates between TSH and the occurrence of endometriosis and indicates a strong positive correlation between TSH and the occurrence of endometriosis. And the last table correlates between BMI and different hormonal levels among endometriosis patients. And from the table, we found out that there is no significant correlation found between the levels of hormones, which are the same hormones I listed, and BMI.
So basically, in conclusion, our results indicated that there was a strong positive correlation between TSH levels and endometriosis. However, the studies are quite limited and further insights need to be taken for that. So further recommendations
would include longitudinal studies with a larger sample size, and that is for the purposes of determining if there is any connection between hormonal imbalances and the appearance of endometriosis. And also, we'd like to do further studies to validate TSH as a non-invasive biomarker for the purposes of early detection and early management. Thank you very much.
Thank you for the presentations. Any question?
Thank you for your presentation. So in Iran, we have this screening that after the 25 years, women are suggested by their endocrinologists that they get TSH test for screening for actually hypothyroidism. Do you have any similar, example, guidelines in your country?
No, the reason we're doing this research is because TSH here is not used as a marker for endometriosis. So our research was to find if it's possible to use it as a non-invasive. Cool.
Is there any screen for TSH?
For TSH, no, but other hormones.
Thank you.
Thank you.
What's up?
No, for the presentation.
Ready?
Now is the last presentation for today from Dr. Rimara Varg about the salutogenic approach to managing irritable bowel syndrome, exploring the efficacy of the food map diet to revive IBS patient quality of life.
Can I start? Hello, good afternoon, everybody. Thank you so much for coming for this presentation. I hope you had a great day.
This
one. Okay. Thank you very much for coming and attending my presentation. My name is Raimara Valk, and I'm presenting my paper on irritable bowel syndrome, FODMAP diet and quality of life, also on behalf of my co-authors of the abstract for this conference, Mr. James Hamill, who is my personal fitness trainer, and Mika Valk, who is resident physician associate in training and who also happens to be my sister. And we will be focusing today on the relation between irritable bowel syndrome, the particular diet called the FODMAP diet, and quality of life. And we're taking a salutogenic approach, which means that we're deviating the focus away from the pathogenesis. So what causes a particular disease towards how can we improve the health of people and their well-being and their overall quality of life. Just a quick question for you. Is anybody familiar with the FODMAP diet? Anybody has heard of that diet? No? Okay. You have? Okay, excellent. Well, not all gastroenterologists have heard of it, so it's very encouraging that you have. But I hope I will be able to share some knowledge with you that you might not know yet. So first of all, we'll go into IBS, and then we will focus on the implementation of the FODMAP diet, followed by how do we actually measure quality of life in IBS patients following the FODMAP diet, and then we will also look at the efficacy in terms of symptoms improvement and quality of life. So what is IBS? Are you familiar with irritable bowel syndrome? It's a very common disorder of gut-brain interaction. And it's multifactorial. As you can see on the PowerPoint slides, there are many factors implicated. And we will focus on, so it can actually already start in early life. So the way you are born and whether you're breastfed or milk formula can all already make a great impact in terms of your gastrointestinal health. But today we will focus on the diet and the food sensitivities. The most common reason why people develop irritable bowel syndrome is after an infection. For example, many of us are common with traveler's diarrhea, where we go to a particular foreign location and bowels habits differ, or you contract an infection and then you may get irritable bowel syndrome. In some people that happens. Okay, how is it characterized? Well, it's diagnosed by the Rome 4 criteria, but mostly you will see abdominal pain, bloating, either constipation or diarrhea or a mix. And there are also symptoms that are not in the gastrointestinal tract, like headaches, loss of appetite. And you can see a female depicted there, and that's deliberately chosen because the disorder is more prevalent in women. So the impact, it's 7 to 23% globally, which is quite a broad range, and we see differences in different regions. Is anybody here from North America or Europe? No? Yeah, you okay. Anybody from South Asia here? No? Australasia? Middle East? Yeah, and that is the interesting thing. There are not many data from the Middle East and not anything from Dubai other than one source I could find. And the prevalence in Dubai or the UAE overall can be up to 30%. So it's most likely to occur in women, 1.5 to 3 more times more likely than men. And the age range, the onset is typically earlier, so between 20 and 45. Now, why is it important? Because it has a high impact, both psychosocial, but also economic. So in the patients, it causes quite a bit of psychological distress. This is mainly because it's not an organic disease. So you can't do a number of blood tests and then definitively say, okay, this is IBS. There are different diagnostic criteria based on which you conclude, okay, this is IBS, but there is no blood test. So people sometimes don't feel validated. So significant impact on quality of life. And it also results in decreased work productivity in some cases, or absenteeism because of bowel issues, or presenteeism. You are present at work, but you can't focus because your symptoms are troubling you so much. So it's quite costly, indirect costs of $2,486 per patient per year. And then on a population level, 41 billion in the European Union alone. And then in the USA, it exceeds the cost of 30 billion, which it includes visits to particular doctors or other specialists. It includes tests that are done, which might not be necessary, but they could be, like endoscopy or colonoscopy, which are costly. And yeah, that all adds up. Consultations. So we are trying to find a way for these people in which we can help them relieve their symptoms. And as you saw on one of the first slides, food or food sensitivities or diet is one of the main factors. A lot of IBS patients say that their symptoms are triggered by food. Now, a great team at Monash University in Australia designed the FODMAP diet. Now, a quick question for you, just to test your knowledge. What are FODMAPs? Number A, fermentable oligosaccharides, disaccharides, monounsaturated fats, and polyunsaturated fats. B, fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. C, fermented oleic acid, disaccharides, monounsaturated fats, and polyunsaturated fats. What do you think? Who wants to take a guess? Who thinks it's A? May I see hands up in the air? Who thinks it's B? Who thinks it's C? Okay. I don't see all the hands up in the air. So, what? It's A, you think? Okay. A. And the other answers?
A.
It's B. What they have in common is these are we call short chain carbohydrates. The other two, A and C, contain certain fats, and this is not implicated in the FODMAP diet. It's about the sugars, the different sugars in the diet, the short chain carbohydrates. And what they do is they draw a lot of water in the small intestine, which can cause diarrhea, and they also are rapidly fermented in the large intestine, which can result in gas production and also constipation for certain people. Now, this happens in everybody. That's not confined to IBS patients. However, in IBS patients, it causes what we call visceral hypersensitivity. So they have a heightened sense of sensation of discomfort or pain. And the researchers in Australia designed the FODMAP diet. So if you look at the picture, there are certain foods that you can have and certain foods you can't have. Now, if you look at the avoid, is there any food on there that you recognize in terms of what you eat yourself? Garlic, beans, onions, who eats these? Who eats garlics, beans, and onions? Yes. Who eats blackberries or watermelons or peaches? Yeah, okay. Almonds, avocados, pistachios? Anybody who eats those kind of foods? Okay. Quick question for you. True or false? Are foods that contain FODMAPs healthy or unhealthy?
Healthy.
Yeah.
But I rather have IBS. I rather have IBS than not eat the food.
Thank you. It's a great answer because it's important to know that foods that contain FODMAPs are by no means unhealthy. In fact, there are many healthy foods, including avocados, for example, and a garlic, are very healthy, but they create intestinal issues for people with IBS. So the FODMAPs contain these are examples of different kind of FODMAPs. So the disaccharides are the dairies, oligosaccharides are found in both fruits and grains like wheat and garlic and Brussels sprouts, and the monosaccharides are different kind of are mainly found in different kind of fruits. Like figs, but also in particular sugars like honey. And then polyols as well, these are sugar alcohols. So they are found both in fruit and vegetables. Also, for example, sugar-free gum, where you have all these sweeteners that end on ol, like sorbitol or xylitol. And these should be avoided by patients with IBS if they're trying the FODMAP diet. Now, how does this diet work? So it's a very complex diet. It's quite restrictive. So you start with an elimination phase, and that's the easiest one in my view. I've done this diet in 3 consecutive years because I myself have post-infectious IBS, and I wanted to try out this diet to see how alleviate my gastrointestinal symptoms. Now, in my view, the easiest is the elimination, because you just eliminate all foods high in FODMAPs. You do that for 2 to 6 weeks. I recommend 4 weeks, because 2 weeks is a little too short. But then comes the challenge phase. That is the more trickier one, because then one by one, you have to challenge each different FODMAP at different quantities. So, for example, you take mannitol, which is a part of the polio P FODMAP, and you take one FODMAP fruit, which is cauliflower, just as an example. And then on one day, you have 100 grams of cauliflower, then you have to have a 3-day washout. Then the next day, you take the 200 grams, so you increase the number of grams, wash out again for 3 days, and then the next day, let's say 400 grams of cauliflower. And you have to do that for each and every FODMAP. So you do that for the fructose and the oligosaccharide. So it's a lengthy process. But by that way, you can trigger, first of all, which foods triggering symptoms, and second, at which amount. And that's a challenge, because there's a threshold. So, for example, Brussels sprouts is high in fructose. 1 Brussels sprouts is tolerable for a low FODMAP. But once it's more than 1 Brussels sprout, it's already high. So it's a very precise diet. And then ultimately what you want to do is personalization. So by excluding all these FODMAP foods, hopefully each patient will find out which particular FODMAPs or which particular foods trigger their symptoms, and then they personalize it. It's very restrictive. So you don't want to, typically you don't want to stay on that diet for months and months and months, because it might also be that foods that you enjoy eating and that actually are not triggering your symptoms are excluded because you think they might. So then you personalize. You find out, for example, you can tolerate Brussels sprouts, has fructose, but you can't tolerate wheat, which also has fructose. So it might also differ per kind of food. Okay, now then we looked at, so we did a study looking at how does doing the FODMAP diet, the elimination, re-challenge and reintroduction personalization phase, how does that impact quality of life and symptoms? So there are 3 different measures of quality of life in IBS patients. The first is health-related quality of life. This particular measure can be used in any medical condition. So it can be used in any disease, health-related, very generic health-related quality of life. Then a disease-specific one is the irritable bowel syndrome quality of life measure. So there you look at particular measures of quality of life that people with IBS suffer from. And it also includes food and but also relationships with others. And your image of your body, because when people are feeling bloated, they're not feeling happy with their physical appearance. So it has both emotional and physical and mental subscales. And then food-related quality of life, which particularly looks at how does following a particular diet affects my relationship with food. And then you assess symptoms as well, so bloating, distension, satisfaction with bowel habits, whether it's constipation or diarrhea. Now, a number of randomized controlled trials and observational studies and cohort studies have confirmed that this diet is efficacious in relieving both gastrointestinal symptoms and enhancing of life. Mostly the studies have been done in the UK, in Sweden and Denmark, a number of those in the USA, but not too many in this region. I have found no studies in the UAE on this topic. If anybody finds any studies that have been done, I've read those. I'm not aware of any studies being done, unfortunately. Typically, the restriction of FODMAPs in the diet is associated with reduced symptoms in 50 to 86%, quite a bit of a range. It also appears to be more effective in people with IBS-D, so IBS predominant diarrhea, and that is most likely FODMAP. If you follow that diet, many foods are excluded from the diet that draw water in the lumen, in the small intestine, and that causes diarrhea. It seems to be less effective than constipation, which actually more fluid would be better to relieve constipation. So overall, it is effective in all the types of IBS, but most of the studies also have been done in people with diarrhea. So that might represent the findings as well. And what they've done, of course, in the trials is compare the FODMAP diet, low FODMAP with medium FODMAP, high FODMAP diets, like the NICE diet. Have you heard of NICE diets? NICE. That is the diet which is prescribed by the British Dietetic Association. It's a very general diet. That diet is inferior to the FODMAP diet. It's symptoms improvement and quality of life. Now, there are also incidences where quality of life might not be enhanced. Do you have any idea what situations quality of life could be diminished? We can extrapolate that to other diets. Bear in mind the FODMAP diet is restricted. There are many foods that you cannot eat. There's still plenty of foods you still can eat, but you're limited to certain kind of foods. And when I asked you, okay, does anybody know about the FODMAP diet? I don't think anybody here has heard of it. Have you? No? So eating, in a lot of instances, is done in social gatherings, social eating. So imagine when you go out to a restaurant and you are on a restricted diet, and that's not only FODMAP, but it could be any other diet. You have to make clear to the person in the restaurant, okay, I can't have this, and then you might look at the menu and think, okay, well, this food is a particular one that I can't have. Oh, this particular dish also contains food. So basically, you have to customize your food, and it also complicates traveling or having social gatherings at work, and you have a buffet, and you don't know exactly what's in the food. So you're constantly, as a person who follows that diet, you constantly have to be mindful of what is actually served to you. So that can create a bit of anxiety or food avoidance, or people might not understand why you're doing that diet. So in that sense, it could decrease quality of life.
3 minutes.
Thank you. The encouraging finding, though, for the IBS patients is that symptoms relief, even after implementing a number of FODMAP foods again, can be maintained 6 months. Of course, it's not something that you just want to have short term. You want to have a long-lasting effect. So now that we know all this, because it has been proven efficacious, there are still some open-ended questions. So it would be great if we could, example, through future research using the multi-omics approach. Have you heard of the multi-omics, like metabolomics, scriptomics, and metagenomics? Yeah, are you familiar with that? I don't know, maybe if you're medical professionals rather than food or nutritionists, you might even know this more than anybody else. But these are particular techniques that are used to investigate the gut microbiome, the microflora in your intestinal tract, the function, the abundance, the diversity. And if we have better insight in those, we can better predict if a person is likely to respond to the FODMAP diet. Because as I mentioned, it's quite a complex diet. And why would you recommend that to a person if you can use the omics approaches to actually sequence their gut microflora and say, well, you know, based on your gut microbiota profile, FODMAP diet's probably not the best for you. That would be great, but we're not yet there. And it would be great through that approach to also find out to which particular FODMAP you are sensitive to, because then you can say, well, okay, I know that I'm very sensitive to fructose, so I fructose, but I can have food with fructose, or I can have food with disaccharides, which is very promising for people who enjoy dairy. So yeah, that is something that we would want to know to enhance symptoms or actually reduce the symptoms people experience. So in conclusion, what we advocate is a salutogenic approach. Salus means health, from a Latin word, and the genesis means focusing on the factors that actually create health and quality of life rather than rigorously going through the etiology, what causes IBS, because you might never find out, and it's also not helping the patient forward in having a good quality of life. And it, of course, requires synergy between gastroenterologists and nutritionists and other healthcare professionals who can work together to provide the best patient care. And that is improvement in quality of life eventually. So that is the salutogenic approach, where you focus on health and well-being rather than trying to figure out the details of what caused the disease. Thank you for your attention. Shukran.
Thank you for the presentation. We have time for a short question.
We have already have friendly food, for example, stores that offer diabetic friendly foods or celiac friendly foods. If this FODMAP also can be industrialized by guys with food companies, it can be very helpful for IBS patients. And well, you mentioned about that no country in the Middle East have investigated the prevalence of IBS. Actually, in Iran from Iran have been some studies, but there are diverse results between 1 to 25% prevalence of IBS. So I have these two comments on your screen. Thank you.
I know, yeah, thank you so much. I know, and I said in the Middle East, you know, with Iran and Saudi Arabia, studies have been done on the prevalence of IBS, but not yes, I want where speak. And yes, thank you very much for mentioning the gluten and celiac disease. Celiac disease is an organic disease. You can do blood tests and you can show, okay, this person has celiac disease, and you know by avoiding gluten that helps greatly. The FODMAP diet does not exclude gluten. It's often the fructose increase that people are sensitive to, rather than the gluten in, for example, oats. So that's the difference. But for sure,
it's more complex, but here too.
Very. But it is alluding to that a lot of people who avoid the gluten, who have IBS for gluten, already see improvements in symptoms. But that could be because they're avoiding the fructose in the wheat and the rye and the barley. Yeah. Are there more questions?